I would like to sincerely thank the members of the Metropolitan Atlanta Study Group for inviting me to speak about TMD this evening. It is a subject near and dear to my own heart, and I'm very appreciative to have the opportunity to speak before you. Would like to put in a plug for the Atlanta TMD Institute. I founded the Institute in 2018 to focus on issues with TMD patients and TMD knowledge. COVID tore us up pretty much, but we persisted. And in 2024, I ceased to do any general dentistry. I retired completely from general dentistry, and I am 100% focused on the Atlanta TMD Institute. The Institute was formed really to educate dental and medical professionals in TMD because so few people within our profession and around our profession know much about TMD. It's very common for patients to go to multiple healthcare providers and never get diagnosed. The second thing is to develop knowledge of temporomandibular disorders. I think that's critical. There's so much controversy, there's politics, all sorts of things happening, and I would like to start doing research. However, that is a future goal, hopefully in the next year or two as we develop the Institute and income comes in so that we can do these things. And finally, to successfully treat patients suffering with TMD. We are a secondary referral source for people who do TMD. So if you run into any trouble, we're there to catch you back. And also, for those that don't do TMD, we are very happy to treat those patients that you wish to refer to us. This particular topic, etiologies of TMD, it's just fascinating to me, and I've been working on a book really for 10 or 15 years now. As I investigate each of the signs and symptoms that appear related to TMD, I update the book, and I'm just extremely interested in it. But I've written a series of books entitled The Biological Approach to Temporomandibular Disorders. This is the first in that series, and I do provide copies of this book to Georgia healthcare providers, primarily dentists, who request copies. This is a huge project to do a 2-hour lecture on the etiologies of TMD. They're extensive, and I wrestled over this a great deal, and I realized that, well, maybe one way of doing it would be doing it in order of how I learned this information, presenting the people and the information as I went. And it just occurred to me that it's been a long journey. Here I am at Harvard, leaving Harvard, going to dental school. Look pretty good, don't I? And I recall a poem that was read to me when I was in high school by a professor, one of the teachers. He brought a group of kids to his home and sat and read poetry, and he pretty much gave up his life. He was a Harvard graduate teaching in an inner city school where most of the kids never went to college, and he read this poem, The Road Not Taken. And I think it's appropriate to my journey through dentistry right now. So let's just briefly hear the poem being read.
The Road Not Taken by Robert Frost. Two roads diverged in a yellow wood, and sorry I could not travel both, and be one traveller. Long I stood, and looked down one as far as I could, to where it bent in the undergrowth. Then took the other, as just as fair, and having perhaps the better claim, because it was grassy and wanted wear, though as for that the passing there had worn them really about the same. And both that morning equally lay in leaves no step had trodden black. Oh, I kept the first for another day. Yet knowing how way leads on to way, I doubted if I should ever come back. I shall be telling this with a sigh, somewhere ages and ages hence. 2 roads diverged in a yellow wood, and I took the less traveled by. And that has made all the difference.
So when we begin the study of a particular interest and we pursue it in a scientific manner, we have certain premises that we operate by. And I think Einstein said it really well. God doesn't play dice. And in other words, like in Newton's world, it's very explainable and there's a cause for all things. And it's very logical. And when we look at TMD and we're investigating different signs and symptoms, we must remember that there are causes. There's etiologies, there's causes, and they're very logical. And that's how we approach each one of the things that we study in order to have a pathway of understanding, a way to approach it, a way to believe, how to look for the answers. You know there are answers there because it is a logical progression. So we are all, each one of us, actually going through that journey, and it's a personal journey for each one of us. Myself, I'm at the end of that journey. I'm 70. I intend to continue practicing until I pass away. I enjoy and love what I'm doing, and I'm hoping to make something important so that I can leave it behind for others. But yet, each one of us, we face things that seem to be overwhelming. And really, the topic of the etiologies is just seems to be very complex and lots to it. And I think of what Sir Winston Churchill said, who I admire greatly: out of intense complexities, intense simplicities emerge. And I'm going to share some of those with you as we go through this lecture. One of the primary purposes things that I've used to measure things is Dobzhansky's statement, "Nothing in biology makes sense except in the light of evolution." Throughout my biochemistry studies and anatomical studies, motion studies, it just appears that there's always a specific purpose. Things are designed in a certain way, and when they go wrong, you can look to see, based upon the original designs, what they're trying to do to compensate. So just wanted to say that that's the lens that I look through when I'm looking at dysfunction or analyzing any biological system. I began my journey in temporomandibular disorders in 1982 while I was still a senior at Emory University School of Dentistry, and a pretty well-known dentist, Dr. Weldon Bell, oral surgeon, who was one of the first pioneers to try to elucidate specifically and outline what TMD was. And he presented over about a week in the afternoons, and I tried to get up there as much as possible. And during that particular time, I realized I knew nothing about TMD, but I was extremely interested, but it seemed to be pretty complex. But it was the first thing that piqued my interest in this subject as a senior dental student. One of the first papers that I read was a paper written by J.B. Costin, "A Syndrome of Ear and Sinus Symptoms Dependent Upon Disturbed Function of the Temporomandibular Joint." Now, this was written in 1934. 1934, probably one of the first people focusing on TMD, and he wasn't even a dentist, but he termed a syndrome of various signs and symptoms as he gave it his name, Costin syndrome. So Dr. Costin was talking about all these symptoms that were occurring in the ear and around the ear and the head because of temporomandibular joint problems. And it influenced his practice of ear, nose, and throat, or otorhinolaryngology. But the things he was seeing was impaired hearing, stuffy ears, tinnitus, pain in and around the ears, dizziness, sinus symptoms, headache. Also headache in the vertex and the occiput behind the ears, posterior sinus pain, and guess what? Burning sensation in the throat, tongue, and the side of the nose, all from temporomandibular disorders. And then Dr. Costin, he didn't put this in. He worked with a dentist, Dr. Willie May. And Willie May did the restorations to relieve the symptoms for the patients that he referred. But again, Dr. Costin said, well, this is all related to lack of molar teeth, badly fitting dentures, which permitted closure over bite. There was deafness, and it was related to the eustachian tubes. And guess this, dizzy spells relieved by inflation of tubes, the eustachian tubes. This means that the jaw, the mandible, has a great deal to do with the eustachian tubes, which relieve pressure in the middle ears. And then tenderness of the mandibular joints, and discomfort that was relieved by putting something in between the teeth or the denture. And it has to do with overclosure. And if you look at the diagram below, we have normal on the left, progressing on to overclosure. And who gets the ringing in the ears, like Meniere's disease and all these other things? Who gets them? The older people that have worn down their face. But yet, ENTs no longer work as closely or as Dr. Willie May and Dr. Costin did. We're going to progress on now to defining some terms. I think it's extremely important because there's so many misunderstood, crazy words. People think of the different terms differently. Let's define some terms because I think it's going to be absolutely critical for you to understand what temporomandibular disorders are and how to diagnose them if you don't know some basic terms. So let's start by defining our terms the way that Voltaire did. Well, when Voltaire got into an argument with somebody, or not necessarily a negative one, he would say, if you wish to converse with me, define your terms. So this is what we're going to be doing now. The first term is the word sign. What is a medical sign when we say a sign? So a sign is defined as an objective evidence of disease. Objective means we can measure it, document it easily, especially as observed and interpreted by the physician rather than by the patient or lay observer. So someone might come in with yellowed skin, the patient may not notice it, but yet the physician will look at that and say, hey, maybe we've got some hepatitis going on here. That would be a sign. I think good examples of signs are stop sign. Now the stop sign doesn't say stop to you. You see it and you know that you have to stop. It signals you in some way. A dead end street sign, these are signs, or no U-turn signs. They don't say anything, you see them and you know something. Now we're going to contrast that with the word symptom. And you see sign and the signs and symptoms of the disease were. So we really need to know the difference between a sign and a symptom. And we're going to do that now. What's the definition of a symptom? A symptom is defined as subjective evidence, the feelings of the patient. I have pain here. Wait a minute. How much pain? We can't measure that easily, can we? Because it's subjective. It's not objective where we measure it scientifically. Subjective is things that the patient reports from their own experience. So it's a subjective evidence of disease or physical disturbance observed by the patient. The patient may not know of signs or doesn't know about signs, but symptoms are things that the patient knows about, complains about, and does not want. So a patient comes in and say, I have headache all on my right side. Oh, and they put the hand on it. you don't know, it's not objective. You can't measure it exactly where it is. You know it's in the region, and the type of pain, all this other stuff you're going to have to get from talking to the patient because it's subjective. Person comes in with a toothache, lower left side, they have their hand on there, you know there's something wrong. It is a subjective pain experience. Or something like fever, a child comes in, mom says she's very hot, she's very uncomfortable, you feel for that. The feeling of the heat is subjective, the measurement of it is objective. So now we're going to get into something very important, the definition of a syndrome versus a temporomandibular disorder. What is a disorder versus a syndrome? Extremely important. They're different. Most healthcare professionals do not know the difference. They don't. And it's necessary to know the difference to make a diagnosis. So a definition of a syndrome. A syndrome is defined as a group of symptoms. They all come together. They're together as a group, right? Which consistently occur together or condition characterized by a set of associated symptoms. And again, it could be signs and symptoms, but they all come together. You see them together. I think a really good example of this is Down's syndrome. A syndrome, again, whole bunches of stuff that occur together, and they always occur together. Anyone in a mall can diagnose a Down syndrome child. They are very recognizable because they literally all look alike because their signs and symptoms are the same. Got it? It occurs all the time, all the signs and symptoms all the time with every single patient. So now I'm going to welcome you into my world because I don't deal with a syndrome like Costin thought. I deal with a disorder, and it's extremely important to understand it. And I'm sharing this with you tonight because it's so important. What is a disorder? A disorder, alternatively, presents with different signs and symptoms, varied signs and symptoms. Got it? It doesn't present the same in every patient. So it makes it difficult to diagnose because you may have some of these signs and some of these symptoms. Another patient has a different number of signs and symptoms. It's different in every patient. A disorder is kind of like a teenager's bedroom. It's a teenager's bedroom, but it's in complete disorder one day. You come back again 20 days later, it's in complete disorder, but it's different. It's different. But you know, in both cases, it's a teenager's disorderly bedroom. So again, in a disorder, a patient's body picks and chooses its own personal combination of signs and symptoms that day sometimes. Same patient can come in 6 weeks later, same patient with a different set of signs and symptoms or different amounts of each sign and symptom. And I make it equivalent to a buffet. Everybody's in the buffet, everybody's sitting in Piccadilly. Every person is a Piccadilly customer. But yet, if you look at their plates and their trays, there's different amounts of different things that come off of the buffet. But yet, they're all eating at Piccadilly. But yet, their meals differ. Same with TMD patients. This is the Kidney-Fund-Stack Visual Index, TMD Visual Index, of all the signs and symptoms at that time that they had were common in TMD patients. And there's many more now. We know much more about TMD than we did back in the 50s and 60s. So the point I'm trying to make here is look at all these different signs and symptoms. A patient can come with a little of this and a little of that and not all the signs and symptoms, but yet all the people coming are TMD patients. TMD can get pretty complicated and confusing at times, especially when you don't recognize what's called comorbid conditions. These are things that may have not totally cause something, but seem to be related to temporomandibular disorders. And there's quite a few of them. Psychological stress, abnormal habitual postural stress, just a bunch of stuff, hypothyroidism, my lord, connective tissue disorders, lots of other stuff that are related to the TMD and often cause confusion because you can't see straight because all these other distracting factors. But we need to, in fact, later, as we develop, understand these comorbid conditions so that we can effectively treat our patients in the right sequences and fully. We as dentists think about teeth a great deal. We're trained to remove teeth, to do root canals for teeth, to do fillings for teeth, to put crowns on teeth, to treat the gums around teeth, to whiten teeth, to do all kinds of things. Teeth, 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 teeth. That's all we think about. And there is a certain amount of myopia that we do have, but we forget that one half of all the perception of the body comes through the face. Oh my Lord, we're working in a place that's highly, highly sensitive. And in fact, teeth come from neurocrest ectoderm, brain tissue, right? You ever wonder why when someone has a toothache, why it's so dramatic? Because it influences the pain sensors of the entire brain. And so it's extremely important to understand that we're working in an area that can have a lot of dramatic signs and symptoms. And that's what TMD is all about. So let's take a quick moment and go over the difference between a syndrome and a disorder. Hopefully I've expressed it well, but a disorder varies in its presentation. Get this, from patient to patient and from the same patient from day to day, so that different variations of signs and symptoms all can constitute a disorder, whereas signs and symptoms of a syndrome are consistently the same. A lot of dentists believe only if there's clicking and popping is there TMD. No, not true. Many believe, well, if they can't open well and they have limited opening, that's the only thing that constitutes TMD. No, that's not true. If the patient can't swallow well, that means that is TMD. No, not true. You have to understand that it's a complex thing with many signs and symptoms. Someone can present with clicking and popping, yes, and that may constitute a TMD, but it may not be all the different signs and symptoms, and there may be others. And if you believe that clicking and popping is the only primary symptom, you're going to miss 90% of your diagnoses. You're just going to miss them, right? Patient's going to say, well, I've been suffering from migraine headaches for years and years, when in fact, it's a TMD headache. But you've never really broke it out or understood that, well, maybe things other than clicking and popping are symptoms of TMD. The next definition is etiology. It's the cause, set of causes, or manner of causation of a disease or condition. I think my training as a biochemist made me demand that I would know how things occurred, where they came from, where the reactants came from, why those reactants were appropriate, where are the products, what happens to the products. These, I think logically, and I always want to know the reasons for things. So when I looked at the Kidney Fund Stack Index, which we show the signs and symptoms, I'd always say, how the heck did that occur? Why is that particular sign or symptom there? And how can I get rid of it? And if I don't understand what caused it, how can I truly get rid of it, right? I don't really know what I'm doing. I'm just doing things to placate the problem unless I address the cause. Therefore, I must know the cause. I must know the etiology. And TMD is complex. It's just not easy. Why? You can't make it easy. And but yet people try to do that. They try to use one appliance for everybody. They don't diagnose before treating. That's crazy. Physicians don't do that. But temporomandibular disorders, the etiology are multifactorial, multi-causative, multi-expressional and multi-interactional, and they involve lots of stuff like airway compromise, growth and development disturbances, postural imbalances, endocrine dysfunction, macro trauma, repetitive micro trauma, vitamin insufficiencies, chronic disease states, sleep deprivation, psychological stressors, spinal degenerative conditions, connective tissue disorders, arthritis, osteo, and rheumatoid. And this isn't the whole list, guys. This is not the whole list. Uh, but I just want to point out there's lots of stuff happening. And if you think mechanical treatment is the only way to go, you're missing the boat, because it's much more complex than that. And you should want to get the patient healthy. And that means you need to know all of the etiologies and address all of them. So it is our joint, the temporomandibular joint. It is a joint, and because it's a joint, it's part of all the other joints in the body. And really, technically, it's a medical issue, but treated by dentists, because that joint has some special qualities that other joints in the body don't have, and so it is a medical problem. This temporomandibular joint that we work with is a highly mobile, loose synovial joint. It's made of fibrocartilage. Hallelujah. Fibrocartilage can heal and reshape. Stem cells will, in fact, create more fibrocartilage. And it's not hyaline, which means if you damage your knee, you're screwed. Ability to change morphology based on function. Absolutely. We don't have a temporomandibular joint when we're born. It's just two open things, and it forms as we go. And as we lose teeth over our lifetime, this joint rehabilitates and rechanges. It changes magically. It's an upside-down, non-gravitational, load-bearing joint. Like the mandible, the TMJ is suspended from the anterior cranial base. It's the only joint in the human body that has a hard stop. When you close, bang your teeth together, it stops. It can't move anymore. The teeth stop it. The teeth influence the joint. It's a compound joint because of its intra-articular disc. It is designed to occupy the anterior extent of the mandibular fossa, not the posterior. This is like, oh my God, this is a difficult concept for dentists to understand, and even some anatomists. It is a weird joint, and we'll go over that in a minute. Now, everything I say, we will prove, and it's not, it's Sitcher proved this in his textbook of anatomy, and people didn't read it and understand it. But we'll pursue this information now. You're usually going to define some structure or something based upon what it does most of the time. And what does the mandible do most of the time? It speaks. We speak way more hours than we do chew. I mean, we may chew 20 minutes total, and tooth contact is less than that, but we're speaking all the time. So it started, yes, as a mechanical trap for food, to kill food, to grasp food. But as we evolved, remember, evolution is important, and speech became critical in our relationship with others and in hunting and in interacting with our universe. That mandible, that jaw joint, that stomatognathic system changed in its purposes. The temporomandibular joint is primarily a speaking joint, not a chewing joint. It must move instantaneously to enunciate and project sounds to form words. Its ideal state is hanging underneath relaxed muscles that respond immediately to neurological commands instantaneously. If you think about how many tissues have to change shape and volume in order to make voices and words come out accurately. And I have these racers here, these 100-yard dash people, because if you look at the Olympics and you watch these guys warm up before their race and you look at their thighs, their thighs are like jello. It's just really soft, movable, incredible. Natural muscle, healthy muscle is relaxed completely and ready to receive its commands from the central nervous system. They're very, very relaxed. That is what normal is. And when we're treating patients, we try hard to have relaxed masseters, temporalis, these all need to be very relaxed. That's the normal state of muscles. So the mandible is an upside down hanging joint, or hanging. The mandible has bilateral too. I forgot to say that in the definition. You know, one thing happening to one joint must affect the other because it's all one mandible. Got it? Very important. But the mandible and the joints hang upside down, out of contact, not pressing against each other like a spinal joint. You ever notice how spinal joints, the vertebrae get bigger as you go down because of gravity, all right? The mandible is upside down. It hangs. The gravity separates the joints. It's a little bit different. Now, if you take some of the links out of one side of the chains on a seat in the swing, you're going to have the kid twisted. And that's what happens when you have masseter muscles on one side that are very tight. You get a change in the cant of the mandible, how it strikes, and God forbid you're putting in some restorations during the time that someone has some severe muscular issues. So this illustrates that the mandible is suspended by the masseter muscle. On the inside, you've got the pterygomandibular muscle, right? You've got the top part where you have the temporalis muscle, all suspended. This is a kind of important diagram because it has infection spaces. And I think in the next 10, 20 years, we're going to see a lot of patients getting badly infected because we have less and less antibiotics to combat this. So, but it illustrates the sling inside and outside the mandible that the joint, the temporomandibular joint, and the mandible hang from. And if you consider what is the mandible hanging from, it's not just the muscles, it's various capsular ligament, like the capsular ligament. We've got the sphenomandibular ligament, we've got the stylomandibular ligament. You've got all these ligaments that are holding and suspending that mandible. In addition to, when we look over on the right side, you have the masseter muscle, the medial pterygoid, inside, outside, right? Then we have also the digastric muscles on the bottom, partially suspending, temporalis above. All these muscles are suspending this mandible below the anterior cranial base.
When I was younger, just a bad little kid, my mama noticed funny things I did, like shooting puppies with a BB gun. I'd poison guppies, and when I was done, I'd find a pussycat and bash its head. That's when my mama said,
"What did she say?"
She said, "My boy, I think someday you'll find a way to make your natural tendencies pay. You'll be a dentist. You have a talent for causing things. Hey, son, be a dentist. People will pay you to be inhumane. Your temperament's wrong for the priesthood, and teaching would suit you still less. Son, be a dentist. You'll be a success."
Here he is, folks, the leader of the class. Watch him suck up that gas. Oh my God! He is a dentist, he'll never ever be good. Who wants that teeth done by the marquis de Sade?
Oh, that hurts! Wait, I'm not numb!
Shut up. Open wide. Here I come. I am your dentist, and I enjoy the career that I picked. I'm your dentist, and I get off on the pain I inflict. I thrill when I drill a bicuspid. It's swell, though they tell me I'm maladjusted. And though it may cause my patients distress, Somewhere in heaven above me, I know that my mama's proud of me. Oh, mama? 'Cause I'm a dentist and a sick cell. Say ah. Say ah. Say ah. Now spit.
I think it's important to think of the mandible as needing to be parallel to the eyes, parallel to the floor, hanging with like a swing seat parallel to the ground and the eyes. Now, in this particular case, someone contracts and there's damage on one joint. That is going to change the yaw, pitch, yaw, and roll of that particular mandible. It's extremely important. This is part of the etiology and the pathology, because everybody says, well, that clicking and popping, no big deal. Excuse me, over time that could cause a lot of problems. And it does in many patients. I see it all the time. But again, we're looking at the mandible. We want it to be horizontal. In this particular case, it's tilted one side because of damage in a temporomandibular joint. So this is my first real important milestone in about late 82, early 83, is reading this book, Clinical Management of Head and Neck and TMJ Pain and Dysfunction. It was written, or the editor was Harold Gelb, and I read the book and it just seemed wonderful. It was easy to read. Everything was nicely presented. He seemed pretty clinical, and I took a course given by the University of Tennessee, but it was given in Nashville. So I drove up, and this guy, Dr. Gelb, was crazy, but he just seemed to present things. He seemed really honest, and all the things he was saying were wonderful, and I wanted to learn it. And I tore that book apart. I visited him much as I could, took as many courses, got to know him, and he was a really interesting guy. He's very practical, very clinical, and some of his concepts come from basic information that he got through the actual practice of dentistry. So Dr. Gelb was a dentist during the Korean War, was stationed on the West Coast, and who is deemed or designated a prosthodontist. And he made dentures, and he made dentures and dentures and dentures. He said he made hundreds of dentures every week. So a person would come in, he learned to do wax rims quickly and accurately. Now think about this. I want you to stop for a minute. This is a critical thought process here. This is the book that we used at Emory, the prosthodontic treatment of edentulous patients. There is a whole protocol of how vertical the face has to be, how the lips are supposed to show, how the anterior teeth are supposed to show, the 2/3 of the retromolar pad to 1 millimeter above the lower lip. All these prosthodontic principles made him able to make rims very quickly. And he got to know this really well. And then after a while, he said, well, wait a minute. Can we apply these prosthodontics established principles that are widely accepted, to people that have teeth? And excuse me, so you could do the same analysis that is done with a edentulous patient on a patient with teeth, and you would come up with some weird results. Now, that is not the sole way that he came up with his techniques, but he did work with a German-born engineer dentist who in New York gave various courses, and he supplemented his knowledge of removable prosthodontics with an analysis, a model analysis that we'll briefly talk about. So one of the key things here that's critical is what is a normal human face, and how does a normal human face relate to temporomandibular disorders? And there is some implication here from looking at removable prosthodontic theories And going back to what Dr. Costin had brought out, and Dr. Mays, who was working with Dr. Costin, when it is correctly aligned at its correct levels, the face looks good. And Grover Dill, Dr. Dill, who was at Emory University Removable Prosthodontic Department, he used to say brilliantly, if it looks good, it's good. He said that, and I always laughed about it, but it is absolutely true. If it looks really good and the face looks good anatomically, it's probably all correct. So, what is a beautiful face? And we go back to Vitruvius, who wrote 10 books on architecture, and most of the beautiful buildings in Rome are built based upon his plans, his theories. Leonardo da Vinci, undoubtedly one of the most important artists ever to be, brought out the concept of facial thirds. He drew faces, so he knew what faces look like, how they're supposed to look like, and he was able in his mind to create lines. The one we're going to look at is the lines of the facial thirds. So this is a diagram in a plastic surgery textbook, and if you look at B as in boy, they're illustrating the facial thirds, and you'll notice that the forehead, the middle face, and the lower jaw are in fact proportionate. It's extremely important. They're proportionate, they're thirds, and you will see as you start looking at more and more of your patients when they come in. I hope that I've contaminated you now so that you don't just walk in the room and say open your mouth and look in the mouth at the teeth, that you start saying, what does this face look like? A quick story, I did orthodontics. I cherry picked, meaning I took the easy cases between 82 and 2006. My first case was a young Filipino girl, and her arches, Filipino arches, they tend to be very flat in the front, very kind of like rectangular. And I had to rethink a lot of things and how I bent the wires and the product I wanted to get. And it made me start thinking about faces a great deal. And this concept has gone on to a facial mask based on the golden proportions, and it's used by a surgeon in California when he designs faces. Interestingly, we have some well-known movie stars with their faces. I guess he's a soccer player on the lower left side, but these show the proportions that are considered very pleasing and correct. So Dr. Gelb developed a three-dimensional upper and lower model analysis where you mark points of the models in the teeth and you make sure that they're aligned correctly in different planes, and you put it on something called the Galletti articulator. You determine the bite, the therapeutic bite. In removable orthodontics, we call it a construction bite. We take a construction bite based upon the model analysis because everything is symmetrical, all the lines have to match, and then you basically get a preliminary bite which you bring to the mouth and finalize it in the mouth. And this is what Dr. Gelb did. It is a painful experience. And later, I started adopting Brendan Stack's philosophy and how he took bites. And he explained, well, I've watched Dr. Gelb in a lot of courses, and he doesn't do model analysis a lot of times when he positions people's teeth and then checks their strength. So Dr. Stack developed his own method, which I subscribe to now, but I sometimes go back to look at models based upon the Gelb three-dimensional analysis. What really amazed me, I just couldn't leave it alone, is that this is a picture of a patient, and these are immediate. So the first two x-rays were taken pre-operatively, And then the same day, right after the first two, Gelb put in his appliance, and look what happened to this particular patient's spine. It actually straightened, and everything got beautiful from his appliance. Lord Almighty. And it just took me years to figure this out, and I have, but it's extremely important that you understand that when you're doing dentistry, you're affecting a lot of the body. And you might say, well, this is a fluke. Well, guess what? We're going to look at Dr. Fonder's results. So to Alfred Fonder did the same thing. He wrote a book, The Dental Physician, and another one, the Dental Distress Syndrome. At that particular time, we were looking at stress, the effect of stress. And he also took pictures, x-rays of a patient that he put his appliance in, lo and behold, straightened out. And he took photographs of the patient straightening out with the appliance in. In other words, you see the patient on the left with his skimmies on, and you look at the right, and all of a sudden you got a straight posture. Obviously the person on the right photograph, that's a different person, but yet also put appliance in, everything gets straight. We are affecting more than we realize. And there's a reason for it, and we'll review that. So it's like I went through these things, and during these periods of time I'm reading this, I'm thinking, this is wild. How could this possibly be? And over the years, I've dug out the answers, and I think we've got them now. So in the early, I guess, 1984 or so, I don't remember the exact year, Joe Councilman, one of my dear near friends, and I love him to death, he kind of adopted me. We just liked each other. When he was the head of oral medicine at Emory University Dental School, he treated you like a human being. He would interact with you in a Socratic method and try to stimulate your thoughts. And I just loved him. And when the school closed, he went into private practice, and he was a closet myomonitor person. Emory probably wouldn't have accepted that whatsoever. But he asked me, I guess in 1984 or so, to come study with him every month with a group of other people at the Atlanta Craniomandibular Society. And I came along and enjoyed it. And I actually bought one of these myomonitors and used it for a few years. But I started realizing that Dr. Gelb's work of looking at orthopedic planes and anatomical bases were more important than a machine telling me what to do. I had some failures with the myomonitor simply because if muscles are really tight and they're really pathological, how can you pulse them and stimulate them to go to the correct position easily, at least in one shot? I don't think you can. The basis of the myomonitor is that muscles are at their correct lengths when bones are in their correct positions. And the myomonitor relaxes the muscle, supposedly to get it at its ideal length, and then you would take a bite, therapeutic bite, and you'd make an appliance based upon it. And I discarded this towards at 1989, I think. It's pretty remember that pretty closely, because I realized I can do this orthopedically, and I liked it better. I like anatomy. I've done 15 human dissections. I just delight in how things are designed. God made, or nature made, a very beautiful human being that works very well. What is really important is that this particular instrument, the myomonitor, was developed by Bernard Jankelson. He's brilliant also. If you look down on the left, he wrote 3 books just on his therapy, how it works. And he was trying to get FDA approval for this as a medical instrument, and he eventually got it. But man, there was so much fighting. Other things that I did not like, because I wasn't in that battle, but I knew people that actually fought in it. There were insurance companies that came to the FDA review and put in briefs and things saying this is not a correct instrument, why would an insurance company get involved in something when it should be the clinicians looking at something that's correct or not correct? This is a scientific thing. It eventually got its approval. And I think in the right hands, if you're making 2 appliances, it's not a bad thing. I just don't prefer it. I think my skill set and what I enjoy is more looking at things anatomically. And I change my appliances. I adjust my appliances. I don't just put an appliance in. It's not like doing a denture. When you put a denture in, you make 1 or 2 adjustments. You don't see the patient ever again. No, I don't do that. We're taking care of signs and symptoms, all of them. And so when I put appliance in, that's just the beginning. I have to adjust it. Once in a while, I don't like it. I'll make a new appliance because I think there's something that I need to change. So there's just a lot of things that we interact with. And it is a different type of therapy versus most of regular dental therapy. I just want to stop for a moment and really recognize Dr. Councilman, Joe Councilman, as one of the most wonderful people that I've ever met. When I was at school, he treated me with respect. When we got out, he followed up. I think he was the one that brought me upstairs to the TMD course at Emory when I first started. Then I think when he went into private practice in Atlanta, he was a neuromuscular guy. Then he invited me to join the Atlanta Craniomandibular Society, and I think it was '84. And I joined, and I really enjoyed it. I did, however, by about '88 or so, stop using the myomonitor. But Joe, I stand on the shoulders of Joe. Sir Isaac Newton said that if I have seen further, it is by standing on the shoulders of giants. And I think that he was referring to Galileo Galilei primarily. And so Joe is the one that stimulated a lot of my thoughts and played a good part in making me who I am. Somewhere along the late 90s, I purchased this book, A Clinical Outline of Temporomandibular Joint Diagnosis and Treatment. It is not hard to read. It's very practical, and it's written by William Farah. This man was hands-on. He worked with a guy named McCarthy, who was a surgeon, and the two of them in Montgomery, Alabama, provided a lot of care to people. And he just wrote, this book is just so good, and so many people steal from this book, and they don't attribute it to it. One major publication in TMD, I think the first book was dedicated to Dr. Farah, and then many of the diagrams were in that particular book. Then given 5 or 10 years later, all the attributes disappeared, and it's a human thing. It's like, if I give power to this Dr. Farah, it means I develop less, I will get less recognition, and it's not true. It shouldn't work that way. But this particular book, you'll see some of the diagrams, you see them everywhere, because he developed them originally. He documented the phenomena, and it explains so much of the actual function of the joint itself. And in the top left, he shows the completely anterior displaced disc off of the condyle and forward. He shows the condyle going up into the fossa, compressing the retrodiscal tissues. That's a diagram. He has diagrams for, a normal. He has it for clicking and popping joints. He just has a lot of stuff. There's an x-ray in the bottom, a transcranial, which I used to take. And notice there's no joint space with that transcranial on the bottom. Joint space is black. There isn't any. The poor tissue was being totally crushed. He also goes about how teeth will deflect because of joint problem. Now get this. You have a joint problem on the left, there's osteoarthritis. You're going to have the teeth hit. You're going to get interferences. So wait a minute, the interferences are caused by the joint problem, and many people go in and they lop off the interferences, when in fact they're happening from the joint problem. And all you're doing is making the joint problem worse because of these interferences were actually protective. And then on the far right, you look at the progression of osteoarthritis, where it goes from nice rounded condyle going backward, hitting, eventually flattening because of the lack of space and strangulation of the blood supply and pressure that exceeds the ability of the tissues to deal with. But these are diagrams that come from Dr. Farrer's book. So this is a very pretty diagram, and it's the reason I put it up. Then I realized it's not very accurate, and I'll show you in a minute what the problem is. So the disc is in red. It's a dog bone, thick on the top, thick on the bottom, and there's a thin intermediate area. And the condyle compresses into that thin intermediate area, right? It's like a glove. The intermediate area presses against the condyle, but also against the articular eminence. So basically, you have two rounded surfaces, the articular eminence and the condyle, and the disc actually accounts for the shape, makes everything match. Got it? There is a capsule around the temporomandibular joint, the far right, far left. You see that there's a capsule. Everything's inside and contained because it's a synovial joint. Then there's a space above the disc and below the disc that can open and close. These are basically spaces. And the next thing is really important. When you look at the articular surfaces of the articular eminence, you have a black thing, and it goes all the way up to the top of the mandibular fossa. While it doesn't in the real person, you can look at that. That black does not go up there. That's the middle cranial fossa. It's thin. If you look at a skull, you can look through the top of the mandibular fossa. It's very light, and the middle cranial fossa is in there. And there have been instances of people who are doing arthroscopies who have gone into the middle cranial fossa because that bone is so thin and caused major problems with patients. But there is no articular surface on the top of the mandibular fossa. Neither is there over the front of the eminence because the condyle is not supposed to go past the crest of the articular eminence. And so also there's not articular coatings on the back of the condyle because there's no articulation in the back. It only goes to the top front. But we're going to look at a video. Hopefully this will give you a little bit of illustration before we jump into an interesting video. And this particular video I think is great. It's called the Yoinked film, and it shows you fresh cadavers with how the joint functions. And please note, the tissues are soft and juicy. It's not, you'll get an idea of how a real joint is. That will be critical, so you'll know that when you're compressing something in the back of the joint, there's something there. There's something juicy and soft back there. Got it?
Functional symptoms, such as clicking and locking, are some of the most frequent findings in patients with temporomandibular joint disorders. Both the normal and pathological anatomy and function of this joint has caused a lot of speculations. Can you, Dr. Eriksson, review the anatomy of a temporomandibular joint?
This is a sagittal section of a right temporomandibular joint. Here you can see the condyle, the fossa, and the tubercle. This is a disc. And here you have the upper joint compartment and the lower joint compartment. fill with blow water in order to stabilize the disc during sectioning. The soft tissue cover on the condyle is thin. This is probably an artifact, but it's also thin in the fossa and somewhat thicker on the tubercle. The posterior band of the disc is situated superior to the condyle. The posterior attachment is a little bit thinner and longer than seen in an absolutely normal joint. The lower head of the lateral pterygoid muscle is seen here, and this is the superior head. The knowledge of anatomy is essential for understanding of joint pathology. During orthography, we have learned that the function of the joint is also very essential. Which are the possibilities to study joint function?
Arthrography, surgery, and arthroscopy can give an impression of the function of a joint, but it is far from easy to understand the complex function of this joint by observing it through a surgical opening or through a thin arthroscope. Videotape recording of arthrography is probably the most effective way of studying joint function today. This technique is, however, not optimal for educational purposes, since the interpretation of the arthrograms requires some training. Dr. Isberg and myself studied the course of clicking temporomandibular joints in autopsy specimens by the aid of high-speed cinematography. This gave Dr. Eriksson and myself the idea of making a videotape of functional alterations of a temporomandibular joint. This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment. In this joint, the disc is also located in a superior position. The disc is biconcave, with its posterior thick part located on top of the condyle in the closed mouth position, and posterior to the condyle at maximal opening. There is, however, a small perforation in the central part of the disc. During opening movement, there is rotation in the lower compartment and more of translation in the upper compartment. There were no crepitation or clicking from this joint during movement. The location of a perforation to the central thin part of the disc is relatively unusual. In joints with disc displacement, it is our experience that perforations usually are located in the posterior attachment and not in the disc proper. When the condyle is distracted downwards from the temporal component, the perforation can be clearly seen. In this joint, the disc is anteriorly displaced and it's reduced on opening with a click. These joints demonstrate reciprocal clicking, which implies clicking during opening followed by clicking during closing. The disc is here again anteriorly displaced. The configuration of the joint compartments corresponds very well to what has been seen on arthrograms and to observations during surgery. Reciprocal clicking is a clinical sign of anterior disc displacement with reduction. In this joint, the disc is biplanar. It's located on top of a condyle, but during opening it's slightly displaced medially, and in association with this displacement, clicking was registered. The posterior attachment between the disc and capsule is considerably thinner than in a normal case. During closing, the disc is again replaced to a more correct position between the condyle and temporal component. The disc is lying in between the condyle and temporal component, but there is a type of reciprocal clicking caused by a mediolateral movement of a disc. The next joint has a medial displacement of a disc. During opening, the disc is moving in lateral direction, and here the disc can be seen. Now it's displaced medially anteriorly again. And here it's replaced to a more normal position and displaced again. Clinically, it can be difficult to differentiate the pure anterior displacement from an anterior or anterior medial displacement. The next joint demonstrates anterior disc displacement without reduction, which implies that the disc is consistently lying anterior to the condyle. During all mandibular movements, the disc is lying anterior to the condyle, and at maximum opening, the disc is folding downwards as seen here. There is a considerable stretching in the posterior disc attachment at maximum opening, and even if the disc is displaced, there can be a good range of motion due to deformation of the disc and stretching of a posterior disc attachment. The next joint demonstrates a large perforation of the disc. There is only a small piece of the disc remaining anterior to the condyle. This joint demonstrated crepitation and irregular movement.
I think one of the critical factors after you've seen the video of the actual joint, and we look at the osteology, the bone on the right side, there needs to be what's called joint space. This is a critical concept when you're reading panoramics or you're reading CAT scans. There is tissue between the bone, and there needs to be adequate space without the tissue getting destroyed and compressed so badly that it can't function. But when you look at this particular condyle in its mandibular fossa, there's plenty of room above, on top, on the back, and the front of the condyle. You need that. go ahead and take our skulls. That you ever come across skulls? Put the teeth together. Take a look at what the joints look like. That's very important. Almost always there's adequate space, joint space. We see below here a outline of the mandibular fossa crossed out and then made into segments, and it is the 4-7 position of Dr. Gelb. In other words, Dr. Gelb says that the condyle should be anteriorly placed in the fossa, and it should be in the 4-7 position with open space around it. I've heard one pretty well known TMD specialist say, "I don't treat joint spaces. I don't treat to joint spaces," and I don't either. I treat to anatomical norms, beautiful faces, good speaking places, and then the joint comes out where it comes out. But I don't take X-rays and move things around based on the X-rays, which his accusation was, and it wasn't correct. But that's the 4-7 position. This is what Dr. Gelb believes is the best position. And guess what? Many of the educated societies are actually coming out saying that this is the best position, most harmonious one. Now we're going to get into the neurology of the temporomandibular joint, and a little bit later on the neurology of posture and how it's affected by the temporomandibular joint. The first study I'd like to look at is the arthrokinetic reflex of the knee. And these two docs, Cohen and Cohen, denucleated, decerebrated, basically took the brains out of cats. And so we know, since the brain is out, that it is all local function. It's not being dictated by the brain. And what they noticed was when you put a little stimulus on the joint, the muscles started responding. And wait a minute, that did not come from the brain. It came from a local reflex. Now, a reflex is mediated immediately at the cord, the spinal cord. It doesn't go up to the brain. It's a reflex. It's kind of like when you sit down and the doctor taps your knee and your leg goes forward. That's a reflex. You don't think about it. It's automated. So we know that when the disc inside the knee moves, there is going to be muscular reaction to stabilize the position of that disc or of that meniscus in the knee. Now, many years later, there was an experiment similar done with the temporomandibular joint. So it's very important to understand this particular study because it affects the muscles in the mouth, it affects the opening, it affects the tension of different muscles because the joint dictates to the muscles directly without the central nervous system getting involved. Yes, the central nervous system gets involved, but there is a separate neurological system between the meniscus and the muscles of mastication. It's very important. And basically, this was performed in 1975. It was published in the British Journal of Oral Surgery by Clark and Wyke. And it's the name is Temporomandibular Arthrokinetic Reflex Control of the Mandibular Musculature. All right. So many docs say, oh, it's okay to click and pop. It can be noises all over the place. Well, every time you hear a click and a pop, it means that there's instability in that joint, which means, guess what? Reflexively, the different muscles have to move around to try to recapture that disc to make it stabilized. And so you'll get a lot of muscular activity, too much perhaps, if there's an unstable joint. Very important. So when you see joint damage one side or both sides, you're almost always going to see muscular dysfunction because it's being driven more than it should be by the arthrokinetic reflex. Very important concept, and basically it makes sense. If your joint's not doing well, your muscles want to compensate and make sure that they stabilize the joint. I had surgery on my right knee. I was dancing and did a bunch of spectacular turns with a young, beautiful dancer, and people actually clapped after we did our practice. But I had tore my meniscus badly and went in. I was out for 6 months, had surgery, and the physician, a military physician, said to me, "You're not going to be able to dance." He actually said it to my wife. "This is terrible. I can't dance anymore," because he took out, he said, half of my meniscus. So I just rejected that completely. And I said, I don't believe it. And I went into the gym and I did very light weights on my knee, but I did it 30 or 40 times, light weights, 30, 40 for about 3-4 months. And guess what? That knee became asymptomatic and the muscles were controlling the knee beautifully, which means that I was able to dance, in fact. So very important concept here. The muscles stabilize the joint if needed. It's not just the integrity of the joint. Normally, all the ligaments being correct, the capsules being correct, the tissues correct, that will naturally stabilize that joint. But if the joint starts getting damaged, the muscles are going to kick in to stabilize. So I'm illustrating a cord level reflex. We have at the level of the spinal cord, we have sensory receptors, sensory nerves. They sense things. They come into the spinal cord through the dorsal root ganglion. And in the case of mechanoreceptors with the arthrokinetic reflex, we have mechanoreceptors, which are like stretch receptors, pressure receptors, things like Golgi tendon organs. Very important. They come in and then they go out immediately without going up to the central nervous system, upward to the brain. These things are unconscious. These happen reflexively. You don't even know they're happening. And we have an impulse out to the muscle immediately when certain of these receptors are stimulated. And that's what happens inside the temporomandibular joint. It has receptors on all the ligaments, most of the tissues, and the joint knows what's going on inside the joint, and it tells the body what's going on. So I'm just gonna, again, I'm pounding the heck out of this because it's so critical. And the concept again is that muscles will support the joint to make sure that it's stable if there's any damage in the joint. Got it? So how the arthrokinetic reflex influences its surrounding tissues. Now, there are no pain receptors in the temporomandibular articular disc. Too bad for that. It can deteriorate and you not know about it. This is really critical concept. Please understand this, memorize it, which means that the muscles trying to support the thing go wild, they start hurting, and people inject dumb Botox into them. They're trying to protect the joint. They're hurting because they're overworking, and someone comes in and knocks them out. Now, of course, there's no pain on the deteriorating articular disc, and it will continue badly to deteriorate because of the Botox injections knocking out the protective mechanisms involved with the arthrokinetic reflex. The articular disc can and often does degenerate with minimal pain because of this. However, there are mechanoreceptors, and the TMJ arthrokinetic reflex will force the masticatory muscles to constantly attempt to stabilize and protect the damaged, distorted articular disc, and also to maintain a stable joint position. This leads to myositis, inflammation of the muscles, myalgia, pain in the muscles, because these muscles cannot permanently protect the TM joint without becoming damaged themselves. Myalgia represents 90% of the chief complaints of all TMD patients. The myalgia is a symptom of the deteriorating joint. There's no pain in the joint, so clinicians tend to focus on the symptoms, not the causes. And it's crazy. And this is something really very important, because some of the protocols that people propose, well-known people and insurance companies, oh, just control the pain and then they're fine. And it's not true. They're not fine. If you've ever done a dissection of the human temporomandibular disc, it is hard as heck. You can't use a scalpel to cut it. It's just thick, thick, thick. And I've always wondered, this tough, thick thing, how does it deteriorate? How does it lose its form? It just doesn't make any sense. And here, I think it's porcine, not really sure, TMJs, and it looks pretty much the same. And we have chicken bone or turkey bone, and you look when you take the turkey out, and you look at the knee, and it's a white, a thick, very bluish white color, and it's hard to cut the leg apart. You have to really cut away, because those tendons and ligaments, they are tough as hell. So the question is, how the heck can something so tough break down when you can't hardly even cut it? And the answer to the deterioration question is, once it slips out of place slightly, the posterior disc gets whammed by between the condyle and the eminence. You think the muscles get tight because of the arthrokinetic reflex, and then over many years, pound, 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 it breaks down. If you look up there, there's some veal, and they are pounding it. I grew up in Boston, and they have these old Italian women. Boy, did they cook incredibly well. And it was a ritual every Saturday. They would go into the market, the Italian market, and they would get fresh tomatoes, fresh, very fresh mozzarella, Parmesan, all this good stuff, right? Then they get flour, and they would make the actual raviolis. They make the actual spaghetti. It was so good, and they spend the whole day making this food, and then they'd serve it. And what was really crazy is, because we grew up in an Italian area, a very poor area, but if they had extra food, the Italians were wonderful. They would say, would you want some pasta? You know, like, oh my God, yes, I would. And they would bring some of that upstairs to where we lived, and it was so good. But it was a ritual. But what am I saying? They got the veal, which is soft to begin, and they would pound it. You got this old Italian lady with a metal hammer, bang, bang, bang. Not just a little. It's been an hour or two banging on that to make it so soft it would melt in your mouth. It's funny, as I got older, I realized how the Italians made veal. And basically, they would take a bull baby, because you didn't want to raise a bull. It couldn't make milk. Its meat was very tough. If you did raise it, you'd have to castrate it just to make the meat softer. But they would take these bull babies, they would put them in a stall in a dark area, raise them without being able to move around, without being able to suckle on their mothers, without any contact to other animals, and then they would slaughter them at 6 weeks. And honestly, when I found out about that, I got sick, because I used to love eating veal. But again, I feel that we are responsible for the fish in the sea, the birds in the air, the cattle and yes, earth itself, and every animal that moves on the face of the earth. This is cruel treatment, and I don't agree with it, and I won't eat it. So essentially, for that disc, that thick, heavy, strong disc to break down, it has to have repetitive bang, bang, bang pressures placed on it, which are abnormal and not the joint was never meant to sustain that type of function. And we look up the car crusher on the left and the car's crushed on the right. But what is sickening is, if you look down on the bottom, there were people in that car, they got crushed. And that's what's happening to the back of the temporomandibular joint with people that have closed vertical dimensions for various reasons. That it's battering the tissues. And we can go back to Dr. Farah's line drawings, and you see in the x-ray in the middle, there's no joint space. And then if you do a coronal section on the top right, you see that there's very little joint space on the drawing, but it's jammed, the joint is jammed up. The right diagram indicates osteoarthritis. So joint space decrease is prior seen to deterioration. So we consider loss of joint space the very beginning of osteoarthritis. Osteo means bone, arthro means joint, itis means inflammation, and basically the distortion of the bone of the condyle and sometimes the articulaminus, but mostly the condyle goes. So you see here a condyle that goes backward, and then it goes upward, and as it goes upward, it displaces the disc forward, and it hits against the bone, and it starts shaping. It gets what's called an osteophyte, outgrowth of bone. You lose shape, and you start getting a bird beak. So you look at the bottom right, clearly that is a bird beak or an osteophyte, which is a pathognomonic, means you see it, you know it, for osteoarthritis. All these patients should be treated. I'm sorry. People say, well, it's deteriorated to the point where it really doesn't hurt much. Excuse me? So if your leg is all broken down, you can still run around, no problem. There are going to be problems down the road, and I feel strongly that we should try, whenever we see decreased joint space, to treat these patients to prevent the forward progression. So we take a moment just to talk about intra means inside, meatal, the ear, outside of the ear, external ear, palpation. This is a very easy thing to do. It is endorsed by the American Academy of Orofacial Pain. Dr. Gelb did it all the time. And it even goes back as far as I could see, is Dr. Monson said you should never make a denture with any impingement in the ear. And if you remember, you have the curve of Spee and the curve of Monson. And Dr. Monson wrote this, I think, way back in the 20s and the 30s in an article, well, actually a discussion that he gave in Chicago. But intrameatal palpation is when you take your pinkies, you push your hand forward, put into the ear, push forward onto the wall of the ear, and bite down all the way into maximum incuspation, all the way down. And if there's any pressure in that ear, it's not normal. You have distal displacement, backward displacement into the ear. You shouldn't be able to feel the back of the condyle in the ear. Remember, the condyle is supposed to be in the front part of the mandibular fossa, not in the back. It's absolutely pathologic when you can feel the condyle going into the ear. So this is Janet Travell. She is a physician, worked with military. I know that she worked in Bethesda Naval Base, and she knew Dr. Councilman very well. As a matter of fact, they were good friends. When she got not very ambulatory, she would invite Dr. Councilman to various places to assist her in where she went. So they were good friends. And when Dr. Councilman invited her to the Medical College of Georgia, I guess in the early 90s, for talks and things, he invited me to come and meet her. And I've had meals with her, sat with her at lectures. She drove me a little crazy. She had hypoglycemia. So her solution was to eat, you know how they have Hershey's, you can break out little squares, maybe about 16, 20 squares out of Hershey bar. And every hour she would take a square of Hershey's and eat it to keep her blood sugar up. She also didn't believe that dentists were doctors. This is just interesting. But she was brilliant, and we'll talk about that. She wrote the Myofascial Pain and Dysfunction book, the Trigger Point Manual. I was exposed to her to some degree by Dr. Gelb, But Dr. Gale didn't do trigger point injections in any of his courses, and honestly, he hardly did them in his own practice. I mean, I visited there, I never ever saw him do a trigger point injection, although he did have courses on doing it. But Dr. Travell was the doctor that introduced the rocker to President Kennedy, and we'll go over what she did that was so amazing in a little bit. So Dr. Travell did something extremely interesting. We know that muscles refer pain. Most characteristic is the heart, left arm. We know about that. We know about this phenomenon. And so she was curious at how these muscles referred, where they referred, and she paid a bunch of Georgetown University kids a certain amount of money, like $50, and she would take sterile salt water and inject the muscles in these little places called trigger points where the X's are. And then she would say, where does it hurt? And she would make these maps. And out of hundreds of kids, over many muscles, she came up with these referral maps. And this is the sternocleidomastoid. It's the most criminal of muscles in the head and neck. It's involved in almost every single TMD case, mildly or badly. It's responsible for bad dizziness, for ringing in the ears, for pain in the ears. It does a lot of wild stuff, and it is one of the things that I am convinced, I absolutely know, that when you have TMD dysfunction, you also have cervical dysfunction to some degree. But if you look at this, we see pain in the frontal area. So it's not frontal sinus, right? It's not the frontalis muscle. It's referred pain from the inner SCM. Pain in the ear. These people go first to their PCP, then they go to the ENT, and then the ENT just scratches his head because he doesn't know anything about Dr. Costin's work, and he doesn't refer, and the poor patient just goes through hell. And then you can have pain behind the ear. Then on the other side, the superficial one, you've got pain in the temporomandibular area, the joint itself, and around the side of the temporalis area and above the eyes. This is crazy because that's nowhere near with the muscle. You have throat pain, and you have also pain right at the sternal attachment. And a lot of times when you compress, they'll start coughing. That's a reflex. And pain behind the ear again. So this is the first one. The sternocleidomastoid muscle also has autonomic things. Autonomic meaning it doesn't have to be pain referral. It could be tearing of the eyes, or in this case, real bad dizziness. Next muscle is the trapezius. It's a trapezoidal shaped muscle in the back, has several trigger points. It refers to the back of the neck, it goes to the shoulder, but look, it goes at the angle of the mandible. How many kids have had their wisdom teeth removed because of the pain in the lower right side? I can't tell you. I've lost count. And the next thing is, look, the trapezius triggers on the top of the trapezius and the shoulder refer pain to the side of the head. Right, so that's the anterior temporalis muscle. So you think I got temporal headache. You can have temporal headache from the muscle overworking. You can have temporal headache from referral from the trapezius muscle, right? You can have temporal headache from the SCM, sternocleidomastoid also, and to the joint. And these are all false pains. You know, you go to palpate, there's no pain, but the patient complains of the pain. And the patient knows the pain is there, wants it gone. The next muscle is the masseter. The masseter muscle, like mastication, is a very, very strong muscle. I think it is the strongest muscle in the mouth. The tongue may be similar, but that muscle is extremely strong, and it refers pain to the upper teeth. Into the ear, it refers pain above the eyebrows, right, into the mandibular alveolar process, and to the upper teeth. So upper teeth, the lower teeth. I know of a picture of Dr. Councilman of a woman who had all of her teeth root canal, all endodontically treated, and the pain persisted. Why? Because it wasn't a root canal problem. The pain wasn't the tooth. The pain came from the muscle, the masticatory muscle. It also will cause tinnitus in the ear, and also we also see in diagram D, look, ear pain. So you can get ear pain from the SCM, you can get ear pain from the masseter, excuse me, and the doctor, they go to ENT, they're going to go to the dentist. God forbid they go to a dentist that has a car payment that month because there's pain there and they feel justified. When they open up the pulp, it bleeds all over the place. It was alive. And we finally, not finally, but almost finally, we have the temporalis. Again, temporalis to the above the eye on the same side, right? You got the SCM with pain on there. You got the trapezius causing pain around there. You got pain from, well, excuse me, masseter can cause above the eye. And now you've got also temporalis above the eye. And the specific places that are all across the side of the head. We have to also differentiate, please. There are two types of pain. Real pain from myositis, the tissue itself hurts like hell. You press on it, there's pain. But these referral areas don't respond when you press on them the same way that the muscles do. They're referred pain. They don't originate from the beat up tissues underneath. Got it? Two types of pain, referred pain and real pain, pain coming from the muscles. And I put the next muscle, the splenius cervicus, because it is extremely common to have pain behind the eyes. The patient feels it's in the brain, and it's coming from the neck muscle, termed the splenius cervicus. Very important. So the last muscle that I'm going to review is the splenius capitis. Capitis means kaput, like the head. So this particular muscle refers to the vertex of the head. And remember, Costin syndrome, he said pain in the vertex of the head. That's where it's coming from. Hopefully, maybe if you sit later and think, we're seeing these integrated things occurring from various muscles and some of the signs and symptoms. We're trying to integrate and understand all of the signs and symptoms. Some come from intra-articular, inside the joint problems. Some come from postural issues. Some come from muscle dysfunction. But what's critical to understand with muscles, absolutely critical, each muscle was specifically designed to do a specific task, and that task is important. If the structures that it supports are damaged, that muscle will have to overwork and it will dysfunction, starting with pain, right? Tenderness and pain. And that's really important. And you have to say, what is this muscle doing whenever you look at pain and say, okay, it's protecting that joint. So there must be something going on in that joint that muscle is trying to protect. So there's a paper that was actually published in 1985, but I didn't read it until late 1989. I don't even know. I subscribed to that journal, but I didn't get to see it. But basically, Dr. Frickton, I think it's the University of Minnesota, he in the paper he says masticatory myofascial pain is the most common cause of persistent pain in the head and neck. Got it? So most people that have chronic pain, it's muscular and often affects the muscles of mastication, the facial muscles, and the cervical muscles. Got it? So listen, man, we've got to know a whole bunch about facial muscles, about cervical muscles, masticatory muscles, because that is the most common place that our patients are having pain in. We need to know about it. But he published this paper here, myofascial pain syndrome of the head and neck, a review of clinical characteristics of 162 patients. And it got me upset. And I said to myself, if the primary cause of problems is pain, why don't I start thinking a little bit about muscle? What can I do to make my muscles, my patient's muscles, healthier? Because if I make them healthier, they will not hurt as much, and I'll be their hero. And this is where I think I first started thinking outside of the box. In other words, beyond the training and some of the reading that I had previously. And basically the statement I'm making here is very important. You must be willing to do everything logically possible to improve the health and to restore the sense of well-being of the patient you serve. The patient is paying you cash money and trusting you to get them better. And you have a moral, legal, ethical responsibility to do that, your very best to help them. To be a compassionate, effective healer, you must be aware of all the influences upon the unwanted condition that is causing your patient's suffering. And this has been my pursuit. Every one of the signs and symptoms, I need to break it down, find out why it's there, how I can eliminate it. And this has brought me sometimes out of the scope of dentistry. Now, I can't practice outside of the scope of dentistry, but I can recommend things, I can refer patients, and it means that I have to do an interdisciplinary approach. I must to get the patient well. For example, so many of my patients have thyroid problems. Many have normal TSHs, and their physicians won't treat them, but they have every one of the signs and symptoms of thyroid disease. And for some reason it's not, and I've got to convince the physician and the patient to put the patient on a pig thyroid. And this was taught to me by an old physician, endocrinologist, got his license in like 1939. And I have his little book, if you want to read it, about thyroid problems. But thyroid problems cause muscle problems. And muscle problems are the most common part of TMD. So wait a minute, if a person has a thyroid problem and I get their thyroid handled, their TMD symptoms are going to reduce. So again, we have to identify, where possible, we're responsible, we treat. If we're not responsible, we refer, and we educate the heck out of our patients. So when I read Dr. Frickman's article, I sat down, became the biochemist I really am, and I started looking at the physiology of muscles and basically asked, what makes muscles happy and what makes muscles sad? And here's Arnold. Arnold lifted and lifted. He said, I would always do more than the next guy because I'm a champion. And that was his philosophy. Today, we know more about the physiology of muscles, that you can lift heavier weights less or light weights more and get the same effect as long as you go to exhaustion. So, but he's the man. When I was growing up, I was lifting, and this guy was like my idol. So one of the things that I take credit for in being brilliant, and I do think it was wonderful, is I sat down and said, how can I help muscles? Did a lot. And what are the things that cause muscles in patients to dysfunction? And we did a 6-week program where we changed their lifestyles, things that they ate, supplements that they took, how they did. And this is in '89. This is even before there was a bill in Congress to make vitamins prescription only, and that failed. Just craziness. But vitamin D deficiency, calcium deficiency. This is everybody. All women seem to be calcium deficient. Magnesium deficiency, vitamin C deficiency, vitamin E deficiency, caffeine irritation, too much intake, nicotine, lack of exercise, Sleep disturbances. Yes, sleep disturbances. 89. I was advising people to go to bed, make their room dark, either exercise in the morning or the evening, taking magnesium, Epsom salt baths, trying to get their sleep improved, and dehydration. So getting them to drink lots of water. Like Dr. Linus Pauling won 2 Nobel Prizes, 2 of them, and he lived until like 96. And one of his advices, which is very hard to keep, is to drink a glass of water every hour that you're awake. Crazy. I didn't go to that extent, but I did 6 to 8 glasses every day of water. But this program, the 6-week program, is one of the jewels, and I treat all my TMD patients with this program first, every single one, because it's almost all of them have deficiencies and problems. Just a quick aside, the 4 Ps are perpetuating factors, which refer to specific events or triggers to the onset of a current problem. Just it happened, it caused it to begin. Perpetuating factors, things that maintain the problem, like vitamin deficiencies, or whatever it might be, things that cause the TMD to continue. Protective factors strengthen the situation to resist the disorder. And then present factors are those that are operating during the time of the event, which are eliciting the distress. These are different ways that problems can present, things that influence the problems. In the late 90s, I think, probably 1990, John Hughes, very tall dentist, very quiet spoken individual, a true Christian, loving. He came up to me like out of the blue. And I don't know, it was like he said, he gave me this book, The Stigmata, a Respiratory Tract Guide. He gave it to me and said, you need to read this. Isn't that weird? That's only happened to me twice in my life. The Body is Electric, The Body Electric was given to me randomly at a conference by someone I was speaking to. He said, listen, you're brilliant or whatever. You need to know this. And he handed it to me. And Dr. Hughes also gave this to me. This is a picture of him before he passed away. And I'm just appreciative. It explains a lot of phenomena. So there is a mechanism, please listen, because it's just, I'm giving it to you quickly, that protects the ear, the eustachian tube. The eustachian tube is a tube which is epithelially lined from the back of the nose that goes into the ear. It equalizes the pressure. So the eardrum, if you're drumming on it, it needs to be able to move back and forth, which means the pressure inside the ear has to be the same as outside so that it can vibrate. Got it? So if you've got your membrane on a drum too tight, it's not going to vibrate. Too loose, it vibrates too much. But this eustachian tube is critical. It has to be open. And when you're eating, you don't want food to go into the eustachian tube. So there is a mechanism that protects the eustachian tube. When you swallow, the tensor tympani pulls the soft palate up and closes the door to the nose. So when you swallow, no food goes up into the nasal area, which means that if you open the eustachian tube at that time, which it does because the tensor tympani attaches to the eustachian tube also, so the mechanism is you eat, you chew, you swallow, you slap up your soft palate, it opens the eustachian tube so that you can get ear equalization between the middle ear and the ear. That's how that mechanism goes. So a poor kid that has a blocked eustachian tube from allergies or infection, that kid is going to clench their teeth, because you have to clench your teeth when you're swallowing, and to open their eustachian tube, and they can't do it. So they're constantly biting and chewing and bruxing in order to keep their eustachian tube open, which they can't do because it's allergenically blocked. Over time, they wear down their pediatric baby teeth. So get this, they lose vertical dimension by wearing down their baby teeth. Then when the adult teeth erupt, they erupt into a smaller vertical dimension because of this grinding. And it is true of many, if not most, TMD patients. And Dr. Meyer Marks wrote this book. He is a pediatric allergist from the University of Miami. And if you look at the right, he describes this bruxism phenomenon. On the left, he used to run around talking to orthodontic societies. Nobody would listen. And he said, listen, guys, allergies, which causes nasal breathing to not be optimal, causes changes inside the mouth, which causes class 2 div 1s. Guys, pay attention. But nobody listened to Meyer Marks. He has several papers that he's published, and he goes over this mechanism, allergy in relation to orofacial dental deformities in children. This comes from the Stigmata of Respiratory Tract Allergies, which is an Upjohn publication. They used to give these away for free. But John gave this to me. It was a wonderful gift. I'm so appreciative to him. And even later when I was lecturing, he used to come up to me and said, I'm just proud to have you as a friend. Just a wonderful man. Made me feel great. And it really was a great study club, the Atlanta Craniomandibular Society. So you're probably thinking, allergies, yeah, bull. And that's basically what the orthodontists did, right? How allergies don't affect joints, don't affect teeth. Well, a guy named Harbold at the University of Michigan said, well, we can't put plastic plugs in human beings. That would be like unethical. We can't do it. Maybe the Nazis would, but we can't. So he took rhesus monkeys and he put plugs in their noses so they could not take them out. And they were obligate mouth breathers. And you started seeing craniofacial distortion big time because of their mouth breathing, right? So we know that mouth breathing causes craniofacial distortions. It flattens out. There's something called adenoid facies and flattens out the cheeks, lengthens the mouth, creates tongue issues, all kind of stuff. And he did these experiments. They were called primate experiments on oral respiration, conclusively showing that abnormal breathing, particularly mouth breathing, causes craniofacial distortion and will also cause TMD problems. And this is just another set of pictures from Dr. Harvold's experiment. I think it was a University of Michigan, where McNamara did a lot of his work, very big name, particularly in functional sciences. So already I've said, well, wait a minute, loss of vertical dimension causes TMD. Allergies, nasal obstruction causes TMD. Now, guess what? We have this dentist, Weston Price, pretty brilliant guy. He traveled throughout the world and he looked at primitive populations that were still eating their natural foods. And he noticed they all had wonderful large arches, natural. Guess what? The third molars, wisdom teeth, were not put there by God so that oral surgeons could have work to do. The patients people actually needed them. They were part of the natural large rounded arches. And I adopted this early in the 90s whenever I was doing ortho. Instead of the narrow wires, I went to the broad parabolic ones because that's what I knew. I just knew that was good, right? And he went all throughout the world and he wrote this book, Nutrition and Physical Degeneration. And he attributed these things to nutrition when in fact I think partly also was these people were chewing hard foods, ate a lot of uncooked stuff, and they exercised their muscles and made their tongue broaden out their arches. And these are pictures Dr. Price took. He has a whole book of these from all over the world showing on the left these beautiful teeth, beautiful kids who ate natural diets, not processed, didn't eat any manufactured foods, only foods that were native to their original area. They looked gorgeous. The ones on the right, these people adopted the American, European way of high wheat products, which cause caries, pre-mechanically chewed foods, so there was no development in the face. And basically, this is what Dr. Price came up with related to teeth. Now, the book has a lot of other stuff in it. It is worth a read. There's also audio on it. I think this book is wonderful. And again, he did attribute it also to nutritional sources. And I do believe strongly that when you take corn and you grow it on soil, and the corn goes down, the roots go down and take all the nutrients out, come up and grows the corn. Now, the second year, you fertilize with chemicals and you don't put any minerals in there. Excuse me, now the corn grows, it goes down and it grabs what minerals it can and brings it up, right? Excuse me, not as much the second time. Well, when you've got corn that's been grown on the same soil for 20 years, there's nothing coming up, guys. It is just the plant has very little minerals and other stuff, micronutrients, bunches of stuff. Plus the roots need to grow down, which means you can't be harvesting them every year. Just a lot of interesting stuff. There is some argument also to the maldevelopment of the human due to nutritional deficiencies, and it is ubiquitous. It's everywhere. The foods, for example, the wheat that we eat is monster wheat, Frankenstein wheat. I forget what the exact name is, but I think in 1952-54, a gentleman received a Nobel Prize for the short-stalked high wheat that he developed, Frankenstein wheat, which had like 86 glutens, whereas the original wheat had like 6 or 8. But irregardless, there is argument for nutritional deficiencies causing issues. It's not just the mechanical chewing. This is a maxilla from a cave in Israel, and it predates the agricultural period, and it is just a huge arch, and it just shows you how big our ancestors used to be, and the genetics supported the fact that those teeth were needed and were integral parts of chewing at that time. So we see underdeveloped mandibles everywhere. I think some outrageous amount, like 75% of people in the United States have class 2, sissy, small, lower jaws that don't meet the bottom half third of a normal face. It's so common, it's almost considered normal. And if you look on the right side, this gentleman has no chin. It's protruded backward. One on the left, much more pleasant profile. This person has a correct growth and development, does well. Then there's just a lot of factors related to this, but we see it. And when you see it, the jaw, the mandible is retruded, which means it's probably, not always, I'm not dictatorial, probably going back and jamming into the ears for various reasons anatomically. And so you need to start looking at mandibles. You have to start also ask yourself, why are we seeing so much of this stuff? Get your mode of inquiry up. Start looking at patients' faces and start asking what's happening when we see this. So I'm going to start throwing some curveballs at you guys, guys and gals. And I want you to think. It's like, okay, so a full maxilla, when they do rapid palatal expansion, there's like a 20% improvement in breathing. Why? Because we have full lateral development of the palate. What's above the palate? The nose. So as the palate expands laterally with a normal full maxilla, you have a bigger nasal apparatus, easier to breathe. Got it? Less obstruction, more open space. Also, excuse me, when you have a sissy little bad lower jaw, which is displaced backward, that also is going to constrict the airway. It's going to force the tongue back into the laryngeal area. It is going to create breathing difficulties, not at the nasal area, but at the laryngeal area. So when we do, if you know, the American Academy of Sleep Medicine states that all moderate and mild cases should be treated with mandibular advancement devices. Now, our colleagues, perhaps that's the reason we don't work so well with them anymore. They do not refer to us when someone has a AHI of 5 to 15 or 15 to 30 when they're supposed to, because when they sell a CPAP to the patient, it costs them $500 and they bill $3,500. They make a lot of money. They're not going to refer. It's a terrible accusation, but it's true. It is. I saw someone give a CPAP to someone with an AHI of 7. 4 is normal. It's just crazy. But what do? We put in mandibular advancement device to assist the patient to breathe. Isn't that wonderful? So we put it in, they start breathing. Excuse me? Maybe that advanced position is where the patient should have been. That anatomically, there were factors that compressed the face backward and caused the tongue to go backward and the mandible to go backward. So I'm going to stop a minute and I'm going to say critical concept. All right. Critical concept meaning if you have to advance the mandibular position forward to facilitate breathing, then this forward position, by definition and by clinical practice, is the natural, most physiological position of the mandible. I have many, not a few, many patients with sleep apnea, got them off of their sleep apnea appliance. Some of these people will get off within 6 weeks of their treatment because we are teaching that jaw to go into its natural position and balance everything instead of it being forced backward. But it's a critical concept, guys. You make if those that make sleep appliances, every time you make it go forward, that's where it's supposed to be in the beginning, during the day, too. So in the front inside of the mandible, there's a muscle called the genioglossus, or the geniohyoid. So the geniohyoid is below the genioglossus. There's little tubercles down there that these two muscles attach to. And when you pull the mandible forward, you're pulling that geniohyoid muscle forward, pulling the hyoid open, and the hyoid forms the beginning of what? The laryngeal area. So you're pulling the laryngeal area open and making it larger. So the mylohyoid muscle also attaches to the mylohyoid ridge on the anterior surface of the mandible. As the mandible advances, it pulls the geniohyoid and the mylohyoid muscles forward, thereby opening the pharynx. The hyoid is the insertion of both the geniohyoid and mylohyoid muscles, so the hyoid bone is also pulled forward when the mandible is positioned forward. This is very important. We are not just moving the jaw, we're opening up the airway with forward advanced positioning. So I like to put a Publix or Kroger shopping bag there. Essentially, when we do an advancement, mandibular advancement appliance, a MAD or device, we're opening the bag up. That's all we're doing. And it was closed to begin with. And we can get into that. The most dramatic reason for it being closed usually is the mandible is retrusive backward and collapse the opening. Now, of course, a fatty tongue, a fatty throat, these are all factors. High BMI, lots of reasons that sleep gets disturbed, but the primary reason in most cases is this mandible not being in the correct position. What gets me crazy is they give him CPAP sometimes without a mouth seal. So the breath, the air goes into the nose and breathes out the mouth, never gets down into the lungs. Probably one of the most important things that have happened to dentistry is dental sleep medicine and regular sleep medicine. There's a lot of politics, and unfortunately, you can get a dentist that goes to a weekend endo course and start taking on maxillary first molars, with secondary canals. This happens, and same thing with implants. But they have courses where physicians go for the weekend and they'll be sold all the equipment for sleep testing, and they'll set it up. I don't know, it costs $500,000 or whatever it might be, and they get 2G per test, and they get a tech to run in the 2 chairs, and they do not have a whole lot of training. They rely heavily on their technician to tell them, and it's all black and white. So, okay, so they have apnea, we're going to put a sleep CPAP in. That's just the way it is. And but sleep is big now. We're seeing kids having sleep apnea and diabetes and obesity, all kind of stuff. We're going to have some sick kids, sick adults come the future, just huge amounts of sick adults. But sleep disturbances, think about it. I've got it in red: tension type headache, TMD; fatigue, TMD, right? A whole bunch of other stuff related to sleep. And now I am focused heavily on the sleep because you heal during sleep. Everyone secretes growth hormone from about 11 o'clock to like 2 o'clock, 10 to 2. And we heal with that growth hormone. And then emotionally, we also heal. We put away all our thoughts during REM sleep, and we heal mentally. PTSD cannot be healed if a person doesn't have REM. I had a soldier who returned from Afghanistan, a young, pretty lady, who got blown up, and then there was an attack from the Afghanis. Fortunately, she got out, but when the Jeep went over and she was stuck, she didn't know if she was going to get shot in the head. And so for a period of time, she was freaking out. And she still lives that same situation every single day, every single moment. She never left Afghanistan. She's still there, and she's still in that moment. But anyhow, sleep is big, and I have a whole lecture on sleep, which I'm going to refer to in the next slide. And I have had many patients who had sleep apnea be cured within 3 months. Not everybody, but many. And I think if I had full reign, I could get most people, but I don't. Here we go. So I gave this lecture in 2022 to the Academy of General Dentistry, and I proposed that sleep apnea and TMD are essentially the same thing with different outward expressions, right? Very important. And I believe it to be true because I've had numerous mild and moderate people who've lost some weight and learned to position with my appliances forward. They've just got better. And we have one gentleman within 6 weeks who was off his CPAP. Fortunately, the physician had a Wi-Fi attachment, and it went to her regularly and routinely, and when she saw the improvements, she called him and said, I think we need to get you off of this. It's just amazing. And it was just within the first 6 weeks of TMD therapy. All right, so up to this point, we've talked a little bit about, all right, what causes TMD? Well, we have airway breathing problems. We have obstruction with mouth breathing. We have lack of chewing. We have nutrient deficiencies, right? We have all these various things. Positional problems also, forward head posture. I haven't really got into that much, but when you have a forward head posture, the elastic, the muscles underneath the chin act like elastics, and they pull the jaw back during growth. And There's just bunches of things. But the next question is, what happens that causes the bone to be distorted? Now, we have learned a lot because of dental implants. Uh, when you take an extensive course in dental implants, which I did 2 of them, 2 maxi courses, we spent a lot of time on bone physiology. How does bone work? What does it do? It's very important. If you're going to put an implant into it, you better know all about it. But the first thing is Wolff's Law of Bone. So basically, Wolff's Law of Bone says bone changes based on the loads placed upon it. This is very important. Even the trabeculi inside the bone, each one of them is like an electric support system for the load placed on that particular bone. When an archaeologist picks up a bone from, 20,000 years ago and says, this guy really was lifting a lot of heavy stuff, the archaeologist looks at the attachments of the muscles, size of the bone, and says, listen, this came from a lot of work, right? So Wolff's Law of Bone says that bone adapts, that secondary changes to the external cortical portion of the bone and the internal remodeling all have to do with the forces applied to the bone. Bone changes based upon adaptations to the stress upon it. This is very important. In weightlifting, for example, you can't just go in there and lift heavy weights. You've got to go through several months of slowly accommodating your muscles in your bone to be able to deal with the weights that you're going to be applying to it. Otherwise, you'll rip tendons and break bones and hurt bones. But basically, bone is dynamic. When we looked at skulls in dental school, we kind of got the idea that they were dry, they didn't change. No, they change a lot. They can change tremendously. They are physiological, right? They're biological. They're not scaffoldings like steel. They change. So we draw upon the orthodontic literature a whole bunch. McNamara's work at Michigan. They have a whole series of symposia going back like 20 years, each year a topic, specific topic. And this gentleman, Melvin Moss, was one of the most amazing individuals that ever lived on the earth. Basically, his philosophy says, called the functional matrix theory. Form and function work together to form a functional unit, right? Evolutionarily, you want a functional unit to be able to run away from a predator, to efficiently chew something or kill something, very efficiently to throw something, right? To digest something. All of these systems have to function well, and their form must also match their function, right? And so we have this functional matrix. It means that the soft tissues, which are functional, change the outward structures, the hard tissues, to accommodate to the function that's needed. Got it? I don't know how this, so let's just read it for a moment. The origin, development, and maintenance of all skeletal units are secondary, compensatory, and mechanically obligatory responses to temporally and operationally prior demands of related functional matrices. What does that mean? It just means that the bone's going to form to the function, right, in order to maximize the function, because the function is survival, and survival is prime. Got it? And it's very important. I'm going to give you some examples of this to prove this theory. And why am I talking about it? Because the face, the lower jaw, the upper jaw, the vertical dimension, the zygomas, everything forms as dynamic. And it's particularly during the growth and development periods. But this is very important to understand. Let's look at some examples of the functional matrix. So function dictates form. Got it? function dictates form. Basically, nature and God gave you the genetic blueprint. It's all there. But then how you use it dictates the final arrangement because it's not permanent, right? It's very, very important to know you might have a very tall genes, but because you don't exercise and don't eat well, you're not going to be tall. You have an environmental aspect upon the organism. Now here we've got these rims making this woman's neck increase slowly over time. The Incas used to feel like these heads that go straight up are very sexy, very leader. They can only be shaped like that if you're a leader. And they would bind the baby's heads and it would grow. This is an example of where the external force causes the structural units to change. Got it? That is true in the human body. Both of these examples, or actually there's 3 skulls and a lady, there's 4 examples of how the body is influenced. The skeletal units are influenced by the soft tissue pressures. And another thing is just crazy. I mean, we forget as dentists, we say, well, this is hitting here, so let's lop off the top to get rid of the interference, when it might come from a joint problem. Or it might come from a tongue abnormality, a speech impediment, something that's causing muscles to push and pull. That's what the problem is, and it's extremely important to understand that. And teeth move towards the direction of force. That's what braces are, orthodontics is, orthodontic wires and ties, elastic ties. But this also includes intrusion and extrusion. So if the masseter muscle is continually firing, hitting, it's going to upward push. It's going to cause the lower teeth to intrude in and the upper teeth to intrude up. And you're going to get decreased vertical dimension. Please understand that. Or you could get severe wear. Both of the things can come from these abnormal forces. Very important. So teeth move up, down, side, left, and right. And they go to the place that equalizes all the pressures from all different directions. In denture prosthesis, we call that the neutral zone. The neutral zone is where teeth live because the pressures upon them are equal in all directions. And again, I'm stating the obvious in different papers, and I don't know why I do that, but I put the taper in to support something that's obvious. Teeth move towards the direction of force applied, also during intrusion and extrusion. Teeth get intruded. They do. And that's how we have a closed bite, a small face, a lower facial third, right? These things come from somewhere. It's the bone that collapses. It's the teeth that collapses. There are forces acting upon these structures which cause the lower jaw not to grow, to go backward into the ear, to compress the tongue. There are forces that cause this. And it's not just the teeth and the environment, but like hydrocephaly. Why does this young, unfortunate child grow like this? Because the pressures upon the cranial bones cause the bones to grow at the sutures, right? And that's a quick mention that suture material and periodontal ligament tissue, they are all kind of weird and same, right? They do wild stuff. And that's why our teeth can move so easily is we have a cranial suture around them called the periodontal ligament. And it responds the same way. But this growth of the cranium is from pressure. This is Moss's theory. It used to be sexy in China to bind women's feet, and or I don't know if there's in Japan too, but this comes from binding the feet right from early age. In other words, the force was inward, and the bones adapted to the inward force. So I was preparing you for thought right now. I'm hoping you're thinking like I am, and you say, what's the elephant in the room that nobody seems to see? And what is the primary cause of underdeveloped maxillas, posteriorly rotated and just backward pushed mandibles, forward head postures, all kind of stuff. And I think I figured it out. I think it is. I think I got the answer. And we're looking for this elephant in the room, and I'm going to say it now. I'm just going to push it right in front of you, and then I'm going to develop the theory behind it. In most cases, it's the tongue. There's Albert Einstein, always kidding around, which is a good thing, having a great imagination and playing around. He said that imagination is more important than knowledge. And that's true, because he was a theoretical physicist, and so he developed theories by thinking about things outside of the box and looking and seeing and then experimentally confirming later. But the tongue is the criminal. The tongue, when you swallow, you place the tip of your tongue over the rugae, right behind your teeth. You don't touch the teeth front, well, you do a little bit. Then as you swallow, like toothpaste, you compress the food up on the palate and backward. And as it does this, the tongue flattens. It pushes right, it pushes left, the teeth and palate, and it pushes forward too. So the forward growth of the maxilla is from the tip of the tongue. The growth laterally is from the lateral portions of the tongue during swallowing. It is an episodic type thing. It's not constant. In other words, you swallow 60 times an hour, you eat occasionally. It's not a continuous force. It's episodic. You swallow, a minute later you swallow, a minute later, and you're putting these pulsing episodic forces causing the maxilla to grow. Essentially, that maxilla grows, and when it does, it frees everything to come forward. It naturally grows forward. Teeth also interdigitate. So if the maxilla is flying forward and outward, the lower teeth have to get into there, and they're guided forward as they interdigitate, and that stimulates jaw growth. These are real tongues. The one on the right, that young lady, it's just like, it's hard to believe, like someone photoshopped it. It's not true. It is actually Andrian Lewis. She's only 15, and it's in Ripley's Believe It or Not. It is a real tongue, and his tongue also is real. It's just amazing. How can he get a breath in? And if you look at his nose, it's twisted to one side. It's like, how does he breathe? I just don't know. But these are real tongues with real people confirmed. So lateral tongue pressure during swallowing and during mastication expands and advances the dental arches. It expands the palate, and it drops the height of the palatal vault. Let's take a moment. Take a piece of paper, arch it up. Now as you take the edges of the paper outward, the arch comes down, the paper flattens. What we often forget is the second story is the nose. So as you expand outward, laterally, and forward, we open up the size of the nose internally. And as a result of that, the patient can breathe better. So when you see high palate, it's robbing the space of the nose. Got it? And that's why we very often, I believe, have deviated septums, because the septum cannot stretch downward straight because the palate's not coming down because there's no pressure from the tongue correctly. Got it? Very interesting concept. So essentially, the swallowing tongue, the placement of the tongue neatly onto the palate, contracting outward, that serves as the template for the size of the maxillary arch. The maxillary arch is immovable. It is on the maxilla, right? It is part of the skull and it doesn't move. Mandible moves. So the mandible is going to move forward as the maxilla moves because of the interdigitation of teeth. The teeth are going to bite, slide forward, pull the jaw, cause growth. Got it? But the tongue serves as a template for the maxillary arch size, form, and position. Very important. So proper swallowing is extremely important to the normal growth and development of a patient. Now, when do we have problems? Well, if you're breathing through your mouth, your brain says to the tongue, get the hell out of here, stay down, we've got to breathe. You can't go up. So the tongue never gets up and forms the maxilla because of the mouth breathing, where the nervous system says keep the tongue down. Or alternately, if someone has a tongue tie, which prevents the kid from going up to the maxilla, that maxilla doesn't develop either. Very important. The tongue is truly an amazing organ. It has no fingers, but yet when you have a little piece of sliver or something, bone, it finds it and spits it out. No fingers. Amazing, right? The tongue also serves as a template for maxillary arch size, form, and position. The tongue goes up into the maxilla during swallowing, seals, squeezes the food backward, but when it does that action, it pushes outward on the teeth, and the teeth move because they respond to force. It pushes forward on the anterior palate over the rugae, causing the front of the maxilla to move forward, and you have growth from this. And it integrates the function of the tongue with the palate so you can swallow. Swallowing is extremely important. You have to be able to eat prey in order to sustain yourself. And also, you have to talk. As our species evolved and we developed speech, we started having these integrated principles where one thing would do many things. And we do speak in tongues. I like to prove my point functionally with guttural examples. This is an example of a patient that has aglossia or hypoglossia. They don't have a tongue, or the tongue is minimal. Look what happened to the upper arch. It never could develop as spread. It never had a tongue to push everything out. This is proof of the theory, no tongue, no development, no arch development. Brendan Stack was one of the smartest men I've ever known. He also was a wild man. He just was wild. A good example is, I think when he was like 60, he married a girl 25. And it was interesting because the last time I actually spoke with him, he was in a scooter and there was a young pretty lady behind him, and I thought it was his daughter, and it turned out it was his wife. And I think she left him not too far after that because he became more or less an invalid. But he just was an incredible man, very smart, very opinionated. He left virtually nothing in writing. That's the difficulty. He did some video studies, a few published papers, but very little. And he did invent, along with Dr. Kinney, Dr. Kinney, Funt, Stack, Index, 3 collaborated to go through these signs and symptoms as they saw them way back when. Dr. Stack also was very interested in movement disorders like tardive dyskinesia, Parkinson tremble, benign tremors, all things like this. And this was like out of the box. And that's how he was. He would just approach things of that nature. So I'm going to play a video of one patient that he had. He has multiple videos. And I remember when I first, he's just a cowboy. I paid him $1,000 to get these videos way back when, and I would be able to watch them. And when he died, they put them up on YouTube. I was like, whoa! So please enjoy this next video. There are other videos on the internet of things he cured, which should whet your appetite in regards to movement disorders and disruption of the human postural system by temporomandibular disorders.
Would I call my local hospital first?
Yeah.
Would that be a place to start?
Yeah,
How old are you?
14.
This is a 14-year-old patient that presented to us with Tourette's.
Hey!
Okay. So what are the tics that you experience?
I have a lot of neck twitches, as you can see. I usually just have to crack my neck. I have to keep flipping the hair out of my face because it touches my eyes and that just bugs me. Hey! I yell a lot. I have a few verbal tics. I have to say things. I haven't been doing those lately though. I've been really doing the necks twitches a lot lately. So.
Do you want to say
keep doing. Keep explaining to the audience.
I have some kicking and hitting tics. I don't actually hit people, but I have to hit walls and stuff, mostly to give off pressure. I bump into stuff a lot. Sometimes I have to bang my knuckle off of something until it hurts. If it doesn't hurt, then I have to keep doing it. Lately I've been doing I have to flex my bones and my muscles and stuff. Sometimes I have to like squint and make faces. Usually when I look in the mirror, I have to. Just because I have to see myself do it. I have to do it in a certain way. Otherwise I have to keep doing it. It has to be perfect or I have to keep doing it. It also really has to do with OCD, my Tourette's. That's pretty much why I have to get it perfect. So. Hey! Usually when I'm nervous and stuff, or if I have more attention, I do more tics. So. It doesn't matter if it's good attention or bad attention, so. I do have a lot of fun with Tourette's sometimes. With friends, we just joke about it and stuff. It's fun being in an environment where kids can accept you for who you are. I was lucky to be in an environment like that.
All the world's not that easy, right? You get cussed out a lot and looked at.
Yeah. I love acting and stuff, but I went to this theater in Spring Grove, and this girl actually came out and cussed me out because she was upset that I was ticking during the play. But I just explained to her I had Tourette's, and I went on with it. I try not to let that sort of thing bother me, so that I can just live on with my life happily. It's not good to focus on that sort of thing. I did have depression from Tourette's around 2007 because I used to let it hit me hard, so just stopped focusing on that. So.
Okay.
We're going to do the best we can for this young boy. Fortunately, he's understands his problem because he has a IQ of 128. These patients are not low IQ children. They're very, very smart, trapped in this disease, and this is what the dental profession should be doing to help these children out all the time. This young man is getting his lower appliance today. We just put it in a few moments ago. And you can see it has caused the diminution of his facial tics and his vocal tics and so on, although they're still not completely gone. They will go away over the next couple of days. You can see that it's hardly barely noticeable in his mouth. Actually, this is a repositioning TMJ appliance because he has bilateral reducing disc displacements in his jaw. I believe underlying all these Tourette's patients, at least every single one that I've ever seen, they all have an underlying internally deranged temporomandibular joint, which has been totally missed by the Tourette's community because they've misdiagnosed all these cases because they have not evaluated them from a TMJ perspective, nor have they taken TMJ imaging studies, particularly MRIs. Open. This is what it looks like. You can see that it's got highly indexed occlusal spaces for his upper occlusion. It's got these ailerons on it to elevate his tongue. That opens up his throat. One of the first things the patient notices is that their breathing increases. Tests show their oxygenation and the oxygen level of their blood rises when they wear this in because their throat opens, their epiglottis moves forward, and their tongue position changes, etc. And this just gets placed on his lower back teeth and is held in place by these clips, and the patient just puts it in and it clips on his teeth, and then he just bites into it, open wide. The best thing to do is initially open wide and then close down into it, bite like that, and that's all there is to it. And that sets his jaw in the correct maxillomandibular relationship to the base of his skull, decompressing the tissues of his temporomandibular joints at the skull base. Say Monday, Tuesday, Wednesday, something in that order, if you can make it back. Okay? Once it's been in, can you make any or discern any differences in your breathing? That's usually the first thing. The breathing, the decrease in any urges to tick or just speak to the audience.
Well, I have this foot tick where I have to crack my ankle all the time, like every time I walk, every time I sit, and since I've had this brace in, I haven't done it nearly more than twice, and that's really awesome. I have barely done my neck twitches, and they've been hurting a lot lately because I've been doing them so much. But with the breathing, I actually thought my breathing was normal like everyone else, but when this thing was put into me, I just felt like clear, like I was breathing air for the first time, and I just felt so good in my throat, like it wasn't clogged or anything. It just feels open. It's really awesome.
Okay, good.
This particular demonstration is related to teaching of the concept that the body knows where it is, and the body integrates things to where it knows it is. Just sounds crazy, but it's a human bipedal postural system beginning. So in other words, I asked the students, sit quietly, close your eyes, take the index finger on your right hand, the tip of it, and put it on your nose. Almost everybody can do that. That is one of the most amazing things in the world. Our body knows where the tip of our nose is in 3 dimensions, left, right, forward, within millimeters. Wait a minute. It knows where the tip of our forefinger is, right? Not only does it know where it is, as that finger moves in space, it's like it's on a trajectory that's well known by the central nervous system, and it puts it right on the nose, right? So it knew where the nose is. It knows where the tip of the finger is at every moment of the movement of it, and the trajectory goes right at that nose. That is amazing. because there's so much control, so much knowledge that we don't even know. There's a little man inside our body that's stereoscopic identified, which is exactly correct for our actual external body. It's so interesting. And that is one of the beginnings of our postural system knowledge. This is a good example of how the different systems integrate and cause pathology in other systems. Now, if you have airway obstruction, partial or full, you're going to have to breathe through the mouth. Now, people that have taken BCLS, basic cardiac life support, as a requirement to their medical dental licenses, they know that to open the oral airway, when you breathe through the mouth, you have to extend the head back to get a straight airway so you can breathe better. Well, our patients who mouth breathe, who are partially or fully obstructed, they also rotate their head and neck backward. You don't see it though, because what they're doing is they're rotating the head backward, and then this is crazy, they're looking up in the sky. That's not acceptable. The neurosensory plane has to be parallel, so they take their whole head and shoulder and push it forward, so now you can see fine while you have your airway open. Got it? So you have a forward head posture as a result of the breathing. But wait a minute, the head's the most important part of the body. It carries, the whole body has to carry it correctly. So there's whole compensations all the way down to the feet for this forward head posture, and including compensations in the temporomandibular joint. So this is a very important thing. And this particular demonstration is where we actually tilt the head up from the breathing, go forward, and you experience that forward head posture. This is a critical but often overlooked truth related to the body. The chief function of the body, in other words, the postural system, all the muscles, all the bones, all the excretory system, the digestive system, right? The chief function of the body is to carry the brain around. We are essentially our brain, our head. Got it? Very important. And when there are disruptions in the function of the head, the body's going to try to compensate to keep that head oriented correctly, right? Because it is pro-survival, right? Most of our function, half of our perception comes through that head, especially vision. And so the rest of the body will in fact distort in order to keep the head level so that it can do its evolutionary safeguarding. Thomas Edison said this. I didn't like him very much, and I'll just jump in there a little bit. Tesla used to work for Edison. Tesla came in, and one day they had a conversation, and I believe it was over AC power, and Edison said, hey, I'll give you $1,000 bonus, an incredible big bonus, and hire you if you develop a AC motor. So Tesla goes back, and he works on it for like 3 to 6 months, and he comes back to Edison and says, I've got it. And Edison says, oh, I was only joking, and it's just the way he was. But in certain things, he was brilliant. And this statement, the chief function of the body is to carry the brain around, is absolutely true. We can cut the legs off, you'll be okay, you can live. Cut the arms off, you're going to be okay, you're going to live. Cut the head off, you're dead. There's no question the head is the most important part of the body. Dentists being dentists, they think teeth. And then even, get this, they think joint, jaw joint, right? But they forget that we are total, that the body is integrative, everything works together. And this particular diagram influenced me a great deal. Goucher was a dentist, I believe up in Chicago. He was also an engineer, and he was looking at jaw function, and he realized, well, wait a minute, look at the mandibular plane, and it goes right through C1, C2 at the pons, right? which means as you move your head, the pivot point, the rotation point, is at pons in the cervical spine. This is crazy. And there are lots of different other considerations here, which I do have. We don't have the time to put it in. The fact is, however, guess what happens right there at the C-spine, right? All of the reflexive, reptilian, functional areas are right there in our brainstem. So in other words, we've inherited them from reptiles: breathing, defecating, chewing. A lot of the cycles that are built into the organism's body are right there. So as we move our jaw around, we're shifting the weight of our head, and we're pivoting off of the dens, which is a projection in C2 upward. That is where the pivot points are. As animals, we are unique. We have a biped vertical posture. This is critical, and it has a lot to do with pathology when we're attempting to maintain this posture. Uniquely also, we rise up vertically in that we can see with our eyes, which is our most important sensation, far away, instantaneously at the speed of light. We can see predators or potential opportunities, prey, or mates, whatever it may be, we see it instantaneously. The human biped postural system involves automatic responses that maintain our balance and coordination in our gravitational system. They are triggered when the sensory system, sensory neurons, detect a disturbance to the posture. Constantly, there is adjustment to keep us vertical, and we don't even think about this because it's part of our unconscious reflexive system, nervous system. Here's the stealth bomber, and it does not fly. Aerodynamically, it doesn't work. Yet, it's up there. You can see it. It does work. And why? Because it has an intricate, amazing computer system that at every millisecond moment is adjusting the flight of that particular plane. Without the computer system, it could not fly. That's why that's very similar to our postural system. It requires immediate, constant attention so we don't fall over. And we have an incredible sense of our body, and we have an incredible sense of the area around our body also. But this particular airplane is like billions of dollars. I forget what the price tag was, but I saw one video of this stealth bomber over Yemen, and over a period of 20 to 30 minutes, it completely destroyed 6 or 7 fighter planes. It took out helicopters. It took out, they even went after like some troop carriers and took the tower control off of the base, just tore it apart. And it's just immediately realized that this huge expense was worth it. Unlike, well, much like I should say, human beings, we tend to steal. And most people are not aware that the Germans were developing a winged aircraft, just a wing. And they never developed, I don't think they ever got it off into the air, but it was on the drawing boards. I just had to put this slide in. It's the Messerschmitt ME262. Let me tell you, man, I had a patient in my early practice who was a tail gunner on a B-17. The B-17's flying fortresses went into Germany and just bombed the heck out of it. And he said that he basically wetted his pants the first time he saw one of these things. It came up at him, he didn't know how to shoot at it. It was scary. Fortunately, these planes could not stay up in the air very long because of their fuel requirements and some other things that had not been worked out. It's just so interesting. If the Nazis had put time into this particular weapon instead of the V1, V2, which were terror weapons, they probably wouldn't have won the war, but they definitely would have eliminated our air power and prevented us from a swift defeat of Nazi Germany. So the human postural system keeps us vertically oriented on 2 feet. It's a very small base that we base everything on. We need this postural system. Bones in and of themselves do not structurally support this biped posture. Very important. They naturally are going to fall to the ground and not be well oriented. So to hold these bones structurally vertical, to hold the weight, because bones hold weight beautifully, we have the muscles. And the muscles move the bones, move the organism. And also, we think about muscles as movement, right? But they also are postural. And specifically, muscles have muscle types that are increased amounts in areas of postural muscles. But anyhow, the muscles adjust constantly. As soon as there's an instability, it responds. If it responds too much, the opposing muscles fix. And it's a constant thing, just like the stealth bomber. So like the computer system on the stealth bomber, we have a nerve muscular muscle system that is reflexive. It happens automatically at the cord level. In other words, as soon as there's instability one way, there's an immediate response to compensate the opposite way. And it does it through sensations, right? There is a arthrokinetic reflex within the joints, which immediately causes the joints to respond. And there's segmental control via the autonomic nervous system to keep the body straight. And it's through this reflex arc. In other words, you have a dorsal root ganglion. That's where all the sensations come from. The mechanoreceptors, the pain receptors, all that information comes up, goes into the cord. The cord then knows when it is related to postural instability, there'll be an immediate response for the muscles. It is a reflexive immediate response. So this design is extremely important in many ways, related to TMD also, because posture and TMD do integrate. And it's not just at the cord level that we have coordination. There is like movement memory that's guided by the motor cortex and also cerebellum. The cerebellum is not as critical as people think, because there are instances of people losing their cerebellums and they still walk and do everything normally. They just can't adapt as well. But again, the brain does have influences, but it's mostly a autonomic reflexive system. So I'm going to briefly talk about protective muscle reflexes. We learned about the postural system and reflexive motions at the level of the cord. We also have other things that can disrupt our postural system, and this is protective muscle reflexes. So these are, what are they? A protective muscle reflex is an involuntary muscle contraction that occurs automatically in response to a potentially harmful stimulus, essentially acting in a defensive mechanism to safeguard the body from injury. And this happens if you have a joint that hurts. That is also going to elicit a protective muscle reflex, and it's going to cause distortion of parts of the body. A good example of this is quickly withdrawing your hand from a hot stove in a classic protective muscle reflex. So it is. Have to have a little concept, a little idea of what nociception is. we all think of pain, and nociception is not necessarily pain. Pain is part of nociception. It's a part of, but other parts of nociception are just harmful stimuli. So what's the definition of nociception? The perception doesn't have to be conscious. The perception of a painful or injurious stimulus, right? It makes, in the bottom, if you look at it, it says to take in, sense, or grasp a harmful stimulus. So in the joint, the temporomandibular joint, there's a disc, and it has no pain receptors. But the other components may be thinking, whoa, something bad's happening here. And that is nociception. And it sends information to the central nervous system, which can respond automatically, reflexively. It also goes up to the brain. The brain interprets it also later. But most of this stuff is automatic reflexive. This is a diagram of a nociceptive reflex most of us are familiar with. If you're near a hot oven and your finger goes near a flame, you sense it. You have a sensory moment from your neurological system. The sense impulse goes all the way up to the spinal cord at that level, but guess what? It immediately, because it's a reflex, connects through an interneuron and goes immediately out, and you withdraw your hand from the flame immediately, and even before you know that you've been burnt. So the pain from the burn is later because the reflex is so fast. And we have this nociceptive meaning negative pain. It doesn't have to be severe pain, but just negative impulse, negative stimuli. And we all respond to this. It's part of our reflexive system. And we're going to look into this reflexive system like the postural reflexive system. They're all integrated with this type of reflexive impulse. I really wish I had more time to develop this concept, but I'm going to try to inject the thoughts into your head. So the head sits on top of the first vertebra, which is called atlas, C1, cervical vertebra. The word cervical means neck, 1, and it literally sits on it, and it rocks forward and back, side to side, and it can influence the orientation of C1. C1 should really be parallel to the floor, like a flat plane, like a waiter holding it up so things don't fall out, all the dishes don't fall on the floor. The plate that the waiter's holding is parallel to the ground. C1 should be parallel to the ground, and the skull rests on C1. The mandible is the only movable portion of the head. So when you move the mandible, you're moving what they call the center of gravity, how that sits upon the C1. Got it? So if you move to the left, there's going to be pressure on the left side of C1. C1's going to go down where the pressure is. It's going to, on the opposing side, going to go up. It's going to tilt, and it will no longer be parallel to the ground. But remember now, these geometric weight shifts, they're not acceptable because the head has to be, the eyes have to be parallel to the ground. So you've got all these changes that are occurring. And the rest of the body takes its cue from C1, C2. And you'll see that in just a minute when we talk about D.D. Palmer, father of chiropractic. The rest of the spine responds to that. So the mandible is the only movable portion of the head. If the mandible is not in correct position and balanced well, it's going to throw off C1, C2. When the mandible shifts, it changes the center of gravity upon C1, and all the vertebrae from C1 down have to rebalance to restore that head position. Because the purpose of the rest of the body is to restore and keep the head postured correctly and working well so it can function and help the animal survive. So again, shifting in the weight of the lower jaw shifts the whole weight of the head, which then shifts the weight of how the head sits on C1. When the body misaligns, the head must be repositioned on C1 to align the head regardless of the posture of the body. So yes, the body aligns the head. But what happens if you've got like a problem with your hip or your foot? You're also realigning the bottom part of your body, which causes pathology. Therefore, the body is not able to adjust the head as well because some of it has other duties. So you get into this craziness of working up and down the spine. We call it kinetic chain, and it is completely influenced by the head and other dysfunctions in localized areas of the body. And then we get into also, and I can't get into this, we get into the fascial system, which is a sensing system. It feels, okay? And it also prevents movement. It does a lot of stuff. That's a whole nother issue. But it all integrates. It's part of an integrative, holistic system. During the great wars of the gods in Greece, the Titans lost. The Olympians won. And Zeus condemned or banished Atlas for the rest of eternity to hold up the earth. And there we got on the left side the Titan Atlas. And has never taken a break, but did for a short time when Hercules took over, and then Hercules tricked him to take the world back. Now he's still there holding it. So if we look at on the right hand side, we have Atlas, the top vertebra, holding up the world, and then we have axis below. There's a vertical tooth in the middle. You see where it says Atlas and axis articulation, and there's an axis of rotation. That axis of rotation is called the dens, D-E-N-S. In Latin means tooth. And it's a rotary thing, left and right, rotating. But then which also causes the entire, dens is part of C2. Got it? It's not part of C1. C2 stabilizes C1, and there's rotation around that. But anyhow, this is how this upper two vertebrae work in rotation. There's also side to side. That's another issue. We talked about that very briefly in the previous slide. But right now, we're just giving you a little bit of a smorgasbord to learn a little bit here and there. So the weight of the head shifts on C1, C2. Primarily C1 holding it, C2 reacting and helping C1. So we have to always open up our minds, and we have to be able to learn. And whenever there's a possibility that the learning could blow away our previous theories, then we are learning the truth more. And we should always, as scientists, have our back door open to learning and even overthrowing previous stuff that we believe in. Now, chiropractic was invented and founded by D.D. Palmer, all right? And Palmer believed that you should only adjust C1, C2, which is not the current philosophy. Particularly, we have Life University here in Georgia, and Life is a whole body adjustment. And we don't want to get into the philosophy too much, but I just want to point out that C1, C2 is extremely important. Palmer believed that it was essential. That's all you needed to adjust. That's all you should adjust. And then we have Roy Sweat, who is, I believe, from Norcross, Georgia, who founded Atlas Orthogonal. Ortho means straight, gonal means angles, and he had a machine that would hit C1 and cause it to level beautifully, and it was very scientific. I had the opportunity of working with him. Unfortunately, just a long story, some disagreements. I was too dogmatic. I should have, he wanted me to talk at his school, or he had a study club. I should have went. It probably would have changed my life. I didn't. We all have our problems. But again, the key here is C1 really, really important. Now, human beings tend to simplify, and they can oversimplify, and they don't understand that things, in fact, can be complex. And there's a law that Dr. Counselman taught me back in dental school, and it was a patient can have as many problems as they damn well please. And it was derived by Dr. John B. Hickam. And it resonates in me now too, because if I think only dentistry is the most important thing and I ignore all these other problems, I'm an idiot. I'm being very reclusive, right? Insular, and it's not going to help the patient fully. My job is to fully help the patient. And by the way, Hickam Field, his dad was a Air Force general, and the airfield that was bombed, one of the main airfields bombed in Hawaii during the Japanese invasion of Pearl Harbor, bombing of Pearl Harbor, with his dad's name, named after this same person's name, Hickam. His dad was the person that Hickam Field was named after. I've always been a little rambunctious. I went from a totally uneducated high school kid, interested mostly in athletics and food, and to a highly educated, thoughtful person by my senior year at University of Massachusetts in biochemistry. I became a scholar. They taught me how to think, right? Very important. Doctors of philosophy are taught to think. That's why all the different degrees, when people become professors, they get their PhD, which is a certified thinker, right? A love of wisdom, a thinker. And I went through dental school, which was traumatic because, right in the beginning of dental school, we were taught, shut up, learn everything as we teach it to you. Dr. Pryles was one of our professors, love him dearly. I asked him a question about an item we were making, and he said, Mark, you don't know anything. The thing is this, you can't even ask the right questions because you don't even know what the right questions are. So go ahead, do what we teach you, and later when you start knowing what you're doing, come and ask me questions then. Right now you need to learn everything that we are teaching you. And what happens is we develop, even as dentists, we focus because all we're trained to do is think about teeth. Remove teeth, do root canals on teeth, fill teeth, adjust teeth, orthodontically move teeth, treat the bones around teeth. We tend to myopically focus on teeth, and it limits our thought process. And it's not just dentists. It's like, different people, like cardiologists. And I have the time on this audio. I had some chest pain. My brother had a heart attack with 3 stents. My mother had a heart attack with 1 stent. I'm having this pain. Go to the cardiologist. He hands me a bottle of nitroglycerin and says, you're going to die. Here's your nitroglycerin. Based upon what you told me, it's serious. Let's do an EKG. He does an EKG, and it's normal. He sits to me and says, wait a minute. Normal EKGs don't mean you're normal. Let's do a stress test. Took 6 weeks. Meanwhile, I think I'm going to die because he's already told me I'm going to die. And I go through the stress test. Results come back normal. I'm normal. The stress test is normal. And he looks at me and says, no, that stress test is normal, but you're sick. Your mother had a heart attack. Your brother had a heart attack. I gave you this nitroglycerin. You're going to die. So let's do a thallium test. That's where they put an isotope in you. It's a $50,000 test, and it goes in you while they record your heart. And so I have this $50,000 test, and at this point, I'm concerned about this guy. So I got a copy of the radiologist's report. What did it say? Normal. So, we got this $50,000 test, which has to be accurate because it's that expensive. Government pays for it with Medicare. So I read it, I'm normal. and I go to listen, sit with him, and it's like crazy. He goes, I don't accept this. Your mother had a heart attack. Your father, your brother had a heart attack. You have chest pain. This is serious. We're going to put you in the cath lab, and we're going to put a wire up through your leg and go into your heart and take a look, because guess what? It's there. We know it's there because your mother had a heart attack. Your brother had a heart attack. Lord Almighty, at this point, I know you can get a stroke from that. You can have major damage, and I'm walking away from this right away because this guy doesn't, he's just insists. Then at the end of that last visit, he goes, I would like to put you on a statin because, and I say, well, my cholesterol's fine. He said, yeah, but I put everyone on statins. I think everyone should be taking statins. Keeping cholesterol low is our goal. And I'm like, oh my God. So I walk away and I go back to my general physician who says, well, maybe this is gastroenterology. Maybe this is a regurgitation, something like that. So I go to Dr. Stiebick at St. Joe's, and he sits down with me, does a conversation, and then he goes, you know, when you eat pizza, do you get really sick? Yeah, I do. And he goes, guess what? You have a milk allergy, and you're regurgitating. Your body's trying to get rid of the milk. And there we go. I could have possibly had a stroke or died or something when it was a milk allergy because the cardiologist could not think in anything else but his own personal myopic training. We cannot be like that as dentists. We need to be leaders because we are just realizing how important our area is to the health of the body, right? It's extremely important. So one, always think out of the box. Two, don't limit your thoughts. Try to, whenever you're treating patients, look at anything you possibly can that might help that patient. We need to relieve ourselves of this dental myopia. When you go back historically and look at dentistry, it's interesting how we've deviated from some of our original pathways. The Baltimore College of Dental Surgery, which was formed in 1839, well before the Civil War, was formed in order to teach dentists. It's the first dental college in the United States. And Thomas Baum was one of the faculties. He was an MD. And he said that the Baltimore College of Dental Surgery was organized with the design of teaching dentistry as a regular branch of medicine, in which relation only it can be regarded as a scientific pursuit and the practice of it esteemed as a profession. Very important concept. Contrary to medical insurance, the body is an integrated whole and the mouth is part of the body. It's so interesting. And physicians don't get trained in dentistry. Dentists get trained in some medicine, but the whole thing is segmented out terribly, and it is not the way it should be. And this is just a concept, and we're starting to see many, like in the oral surgery area, getting DDSs and MDs. This is going to be really critical in TMD because treatment overlaps many different professions, and we need to develop a treatment protocol to allow our patients to be treated seamlessly without running all over the place, and also one integrated mind looking at this case and resolving all the problems and being the end person providing the care. So this particular lecture was to explode myths, right? And we're kind of wrapping up, but I want to do another demonstration. And this demonstration shows how the neck and the body can affect the bite, because everybody thinks that the bite's stable, it's always the same. It's not. And I'm going to prove it to you. So stand up, straight, head back, tap, tap, tap hard. Now, bend your head to the left as far as you can. Tap, tap, tap hard. Bend your head to the right as far as you can. Tap, tap, tap hard. Rotate your head back as far as you can. Tap, tap, tap hard. Go forward. Tap, tap, tap hard. This should prove to you that the bite changes with the orientation of the neck. So problems with the neck will affect the bite will affect the occlusion, will affect the way function occurs. Many people do not understand this. I had one specialist, we can't really use that term, but did a lot of TMD, and he would send me occasionally cases that he couldn't resolve. And almost always it was what? It was the neck was jacked. It couldn't move. It created problems with the movement of the mandible. So you've got to treat both of them. Very important. I think I'm presenting this at the end of the presentation because you had to know all the other things. So if you had a joint that's getting crushed, or the tissues behind the joint are crushed, the muscles that pull that jaw forward are going to go pull it forward. And as they continue to pull it, they're going to fatigue. They're going to start getting inflamed. Then they're going to start hurting. Got it? Very important. So the pain is coming from them not being able to protect what they dearly want to protect. That's the joint. We also have the regional thing where you start stretching your painful joint to separate it, pull it off of the retrodiscal tissues, and then your head has to right and your whole body gets distorted. But many practitioners will say, well, you're having pain. Pain is the most important thing. So I'm going to inject with Botox your painful muscles. All right, so you inject the muscles, wonderful, pain goes away. But wait a minute, what were the muscles doing? They were pulling the condyle off of the back of the tissues. Now, guess what? You continue to have degeneration in the joint, leading perhaps to osteoarthritis, other various problems, because you're knocking out the symptom, the pain from the muscle trying to protect the joint, rather than the reason for everything, the deterioration in the joint. Very important. And intraoral appliances that are properly made can relax, can support that joint and do the same thing that Botox does without continued injections on a repetitive basis, which end up being very expensive. I also want to make a point that in dissections in Germany, I think about 10, 15 years ago, there was a young scientist who put dye in, a nerve dye in a skull. He split the skulls in half, put them in shake and bake bags, put this nerve dye in, and then cut up the skull. And he noticed that the nerves inside the skull, which is the dura, which is the rubber lining of the swimming pool, the rubber lining of the brain, those nerves go out of the skull into the muscles, the attachments of the muscles. And that's why when you use Botox to inject the attachment of the temporalis muscle, migraine pain goes away. Oh, Lord of money. That means that muscles trigger the migraine pain. Oh my God. So this is just things to think about, right? Things that that make you understand what's going on, because inquiring minds need to know. So just indulge me for a moment, and if you're a dentist, you're going to immediately say, oh my God, look at that. We have a pretty flat occlusal plane. There are open contacts in several areas. Oh my God, these teeth are very long, and there's some disorientations. Look at that lateral, that right lateral on the maxilla. It's whacked off to one side. Teeth, 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 teeth. Oh, there's quite a few fillings in this particular person. But then did you look up and see that of the two joints, there is very little joint space between the condyle and the articular eminence. This person, from their grinding, has very little disc that's been damaged. Wait a minute, the nose is completely obliterated. There's no black right and left side indicating the person who breathed. We didn't look at it because we're dentists. I want you to start looking at things with a different viewpoint. I wrote a book on the signs of temporomandibular disorders in panoramic radiographs, and because you can learn a lot from reading these panoramics, and it breaks you out of this dental myopia of thinking only about teeth. So one of the things that that I want to offer the people here at our lecture, the dentists attending, is you're probably went through this whole thing and they're thinking, okay, what can I bring home? How can I make some money to pay my way, because money makes the world go around and I have to have a little of that. What can I do? What's practical? Kind of like what Dr. Gelb would think about. And I have a free course. It's about 6 to 8 hours. It teaches you how to use a very easy to make in-house appliance, and it teaches you how to manage it, how to do exams for this, and it's free. And it's with Teachable. We may switch to another company. Please email me at drpodolsky, Padolsky, @gmail.com. And if you're a dental professional, I hopefully will still be offering this free. I know right now we do. So let me know. This will provide you with you and your staff integrating together to help patients in your practice. I'm very proud of this. The Institute also has a Atlanta TMD Institute homepage or channel, and there are lots of interesting videos in that area. You should look at them. One should be the signs and symptoms of TMD. It's in the patient section. I believe it's the first video, because most dentists don't have any idea of what the signs and symptoms of TMD are. And even this particular video doesn't have all of the signs and symptoms. It's based on the Kinney-Funt-Stack visual index, which is like formed in the 50s, right? There's more to it, but it is a wonderful beginning. So please visit the Atlanta TMD Institute. Please take a look at the videos. They're there for you, and there's lots of interesting stuff. Hopefully we'll start developing it more now that I am completely retired from general dentistry and doing only TMD. But as more patients come in, I'll be able to get an associate who I can personally train, and then I'll be spending an awful lot of time doing educational writing, doing video, making sure that the information that I have gets passed on. There is just a bunch of stuff. There's a section, a playlist for doctors only, and go in there. There's one for ENTs. There's an extensive 4-video stuff on signs and symptoms where I really delve in deep to try to explain more about each one of the signs and symptoms so that you get a better full understanding. It's obviously not complete, but it's really good for a starter. So we return to the concept of the great journey, and I'm at the end of my journey. At age 70, I realize my mortality. Many of my friends, relatives have passed away, and now I feel an urgent sense to pass on information. And I hope that this lecture, in fact, gives you some tools, some thoughts, and things that will be helpful in your own personal journey. I wish you the very best, and thank you so much for spending your time with me and listening to this lecture. I'm very greatly appreciative, and God bless.